are in listen-only mode.
Okay, well, good morning, everyone. It's wonderful to see you all on this gorgeous day. We're going to get started now, so if everyone could please chill. Okay, great. So you all are familiar with this facility now, but if you're not, there's coffee up here. Restrooms are out in the hallway, so please feel free to take advantage of both, even though we will be building breaks in this morning. So I'm really looking forward to this today. We are focusing the entire meeting on behavioral health and physical care integration, or as we call it, although I just continue to amaze myself that we have to call it whole person health care, as if that's a novel idea. So, it's just basically the integration that we need of our behavioral health and our physical health care systems so that any person that's got issues or problems or needs care can go through one door and hopefully get everything that they need. In your packets there are elements just for referral of what we are actually doing kind of programmatically with behavioral health if you need those, including the status also of our Healthier Washington accelerator committees and other updates in general on Healthier Washington and HILM. So because we've been listening pretty carefully to the feedback that we try to get at the end of every meeting, those little 20-minute spotlights that we've been doing seem to be not enough time to actually dig in and spend the time that people want to when you start to actually use real-life examples and want to kind of go deeper with what we're doing. So we're going to spend the whole day with a pretty intense focus on physical and behavioral health integration. I think it was in January of this year that we requested this as a topic. So here we are today with that. And I think the other thing that hopefully this day will show is how all of the sectors we have in our state need to interact to really do a good job of integrating care, service, referrals between our health systems and our communities and our government entities so we can work together on this. The other thing we heard was that it would be great to have more consumer voice. We've been having anecdotes and videos with consumers, but really have folks in the room with us to talk about the real life on the ground experience as we've been moving forward with hopefully some lasting improvements in our behavioral health and physical health systems. So we are really privileged today to have Kay Roberson with us from Clark County. She's sitting up here next to Dr. Bob Crittenden, and we'll be hearing from her today. And I trust that she will tell us the truth about what's going well and what isn't in Clark County, and that's obviously what we want to hear. So just speaking of Clark County, I took the opportunity, I think it was in the last couple of weeks, I can't exactly remember anymore, to drive down to Clark County for myself just to get kind of on the ground talking with a couple of the county commissioners down there, with Vanessa Gaston, who's a key leader in integration, physical and behavioral health, and actually to talk to a couple of our legislators that are from that area as well, to get a sense for myself about what's going on and what are we learning and what's next on the agenda, even in our early adopter region in Southwest Washington as we're integrating in Medicaid program our physical and behavioral health systems. And what was pretty awesome, at least for me, was to hear, number one, how everyone is all in to make this happen, whether it's the county commissioners, whether it's public health, whether it's the behavioral health system down there, whether it's our health plans down there. We have both Molina and CHP working down there, whether it's our care delivery systems themselves, or whether it's the Healthcare Authority, or whether it's the Department of Social and Health Services, or whether it's our legislators. I was really struck with when I've been hearing about what's going on and the all-in concept down there, to actually personally experience it was pretty remarkable for me. And as part of those conversations, of course, you always hear what you can do more and what you can do better. And I think we're going to hear more of that today as well. This is a absolutely vital part of the improvement in healthcare transformation, health systems transformation in our state, not just for Medicaid, not just for our commercial population, not just for our Medicare population, but for everyone. So as we build these systems, they're going to work for everyone better than they do now. So we're going to hear today kind of a work in progress, where we are, what we need to do next. And as usual, we're hoping this is candid. We learn what's working, what isn't, and where our aspirations are being put into action. It's not like a miracle occurs and you're here one day and the next day you're in a perfect setting. It's not the case, but we've certainly made huge progress, and we want to hear about that today. So with us to introduce this and to be our guides for the day, Bob Crittenden's going to open with us on terms of the governor's perspective on health systems transformation, and in particular how it relates to this. And then Teresita Batteola and Joe Rozak, our co-chairs of the Accelerator Committee for Behavioral Health, are going to be also kicking us off with a dialogue, inviting Kay up as well to participate. And we'll go kind of topic by topic that you see in your agenda. Laura told me that I might have to be a little bit of a strict timekeeper, and I'm going to be relying on her and others. If you suddenly see slides flip, we're going to go, oh, I guess we have to be done with this. But we're hoping that at the end of each section we have at least 10 minutes of questions, dialogues before we go to the next section of the discussion. So I will be trying to keep us on track, because we want to make sure we've got time to go through everything that's on here. So again, today we really want to understand how we all are working together, how it literally, I don't know, takes a village, I guess, takes a state to work on something like this. That I don't think there's probably anyone in this room that does not have some kind of a personal experience with our behavioral health system and how it does or does not link with our healthcare system, and how it does or does not link with our governmental programs. So this is an issue that there's just vast room to improve. If any state can do it, it's Washington State, and we're here to spend the morning trying to figure out where we are and where we need to go next. So with that, I'm going to invite Teresita and Joe and Bob and I believe Kay all together coming up. I'm just going to turn to you guys and see how you want to start. What? Oh, so hang on a second. I forgot something. I was on the wrong page of my annotated agenda. The first thing that's going to happen is, no, you guys are going to come up and talk about your vision, right? And Bob's going to then introduce this with the governor's vision and the legislative direction. So maybe that's what we should do first. Is that right? Okay. So Bob, you're up. I am so sorry, you guys. This is my problem because the notes weren't quite read.
You're fine. It's good not to be entirely organized all the time. And anyway, I just want to hit the high notes, and we're going to have a lot of different activities this morning. This behavioral health issue and behavioral health integration, how it affects people's health is really important from my own experience being a provider, where this is a huge issue in all primary care. But when we talk about what the governor wants out of this, I'll just say that if you look at what he wants out of our health system, and that includes our behavioral health, mental health, substance abuse, medical care, is that he wants us to come back, and we have a very rigid sort of internal discussion oftentimes about how are we getting results out of government? Are we really doing what we should be doing? He wants actually people's health to be improved. To do that, he wants to make sure we have a system or the systems in place that can help, from our perspective, help support the rest of the system in making those changes that are important to do. And that actually means that we have to change what we're doing. And that means we can't just be passive about healthcare. You know, in the past, we've always waited for people to come into the doctor. We have to identify people. We have to actively manage them. We have to make sure if they have behavioral health problems and medical, that they get both and not just one or the other. We need to have a system that actually supports the patients and supports the providers in how they change what they're doing. So you've heard a lot about Healthier Washington. There's a lot of activity in all these things. But that's kind of his general vision. That's what he wants us to be doing and getting to. But, you know, the reality is a lot different from that, as you know. It's very disorganized. You know, you can tell by our fights and discussions about the hospitals that we have huge, I'll say, challenges in that area that we have to improve. If you look at any numbers of how we're really doing in behavioral health, there's debates over whether the numbers are accurate or not, but we're not at the top and we're not in the middle, and we're probably down the low end. We have a lot of improvement we can make. And I've gone around and visited a lot of different systems over the last few months around the state, and there's a lot of variability. There's some that are excellent, and there's some that are okay, and some I don't know. And one of the things we don't have right now and that we're developing is, how do we measure? How do we know where we are now, and whatever we do, are we going to be better? So we need to make sure we're accountable, that we, in fact, are able to measure, to make sure we're doing the right thing and can make those kinds of improvements. So from the state perspective, what we're doing is we're doing a number of things actively right now. As you know, legislation passed that said we're going to be completely integrated by 2020. We have been very encouraging of the Southwest Washington earlier adopter. We'd love to have more communities move into mid-adopter, because it just helps us make those steps in a more, I'll say, organized way. Instead of all one time, we all make a big turn. So what we're doing internally, though, is we're actually decided that the state has to get aligned. The state has to be organized, and we're actually bringing together DBHR and HCA. We're going to reorganize government. I hate the idea, but we have to do it so that we can put the funding under one source, so that we can have integrated financing, so that we can treat the whole spectrum for the patients. So if somebody has medical problems, I'll say mild or moderate or severe mental illness, that they can go in the whole spectrum. So the financing system, so we don't have the system now where we are in one whole agency until you move from moderate to severe. And once you hit severe, you change agencies as to where you get your care. And the systems are different. And we need to look at what the patient can do and how we treat the patient the best way. So we're involved in that process. And obviously, to make this really work, we have to have it work at the front end. That means the providers have to be able to provide that care, have the support to change. The medical side probably has the biggest lift to do, in the sense that they have to start really doing much more active and engaged and coordinated care for the mentally ill, along with their medical care. So we have a whole work being done by John through a Department of Health, where we're reaching out and supporting practices to change. And in doing this, you probably have heard that we have a lot of studies going on. The recent bill passed has us looking at the whole healthcare system, mental health, and how the hospitals fit in, how the medical care system fits in to that. So we have a group called PCG doing that study. We're doing a study also looking at keeping people, diverting them from jail. What can we do at the state level to help change laws or other activities that can help local communities support them in keeping people who are mentally ill out of jail, and also looking at how we transition people back out of jail, back into the community and better treatment. We're also looking at workforce issues and a number of, I'll say, more technical issues around hospitals and staffing and things like that. So there's a lot of activity going on. It's almost too much. We, in fact, actually have a coordinator for all the different studies, just because we have to keep our eyes on all the different pieces. But these are really important. And the discussion today, I think, is a good step to start thinking about. We've taken a small step now in Southwest Washington. What can we learn from that? And today we're going to have that chance. We're going to hear from people who are actually working there. And we're also going to hear from a woman who actually experiences it, both as a patient, but also now as a participant. And her name is Kay, and I used to have a patient my wife used to laugh about, because I'd be on the phone with her, and I'd say, "Okay, Kay, okay, Kay," and she always asked me, "What the heck are you talking about?" So it was really fun to see her. Anyway, we'll go into that. So thank you very much. And who's my next? Joe, I think you're on the list. Thank you. This is Joe Rozak. And Joe?
Thank you. Were we able to get the PowerPoint in or not? I'm sorry? After the break? Okay. Well, then I'm Joe Rozak, and I'm happy to be here today. I represent the behavioral health organization aspect of integration. So we provide not only chemical dependency, but also mental health services. We're underneath one roof. In addition to that, we have primary care services that are co-located from both the community hospital puts a physician on our campus, as well as the federally qualified healthcare center puts a physician on our campus for and an MA medical assistant for services. And in addition to that, this fall we're going to actually open up 4 dental chairs on campus. And then the last thing I have to shoot for is vision, right? And then I think I got the whole person care. So the point is that clinical integration, if I have the opportunity to share with you, we did a statewide survey of different agencies, and we have a random sampling from little itty bitty ones that are on the coast to mid-sized ones to the humongous giants that are located in King County as far as what they're doing towards integrative care. And it's a fascinating 10,000-foot overlook, the fact that many of us have been working at integrated care for over 5 years. It's nothing relatively new, because those of us on the front lines have recognized this as a primary need. It's critical for the individual coming to us for services. And I've shared my story with many of you where I had one of our individuals who uses our services. We don't say patients, we don't see clients, we see individuals, we see people. And she came in for services. She was extremely ill, and it was a Friday, and we said, you really need to see someone about, you sound really terrible, you're having trouble breathing. And she promised she would, and then as she's going out, the receptionist double checks, make sure you go and call directly to a doctor, don't stop, go before you go home and all that stuff. She said, yes, I promised to do that, and hacking and wheezing, she left. We found her the following Tuesday on a house check because she wasn't responding. She had passed away due to complications of pneumonia. She did not see a physician. So the consequences of not having integrated care are causing people to die. And that's the reason why we on the front lines have been pushing towards integrated care. And you will find and hear that from my colleague as well, as far as in the primary care services, there's been extensive advances being made there as well. So that's my speech on integrated care. I'll turn this over to Teresita.
Thanks, Joe. I'm Teresita Bacheola. I'm CEO of International Community Health Services, which serves over 50 different languages, not just Asian languages, but East African, Eastern European, Spanish, of course, is very big in our system. But I'm not going to talk a lot more, because I think what you're going to find out, there's really a lot of efforts being done around the state, and it's all very uneven, and a lot of it depends on, the commitment of the systems providing the service to, in fact, make a change. And sometimes it's the very hardest thing to do is to change ourselves. And so I'll save some more of my remarks for the panel that I'm going to facilitate, because I really think it's important that we get to Kay Robertson and really start us off that way, because she has really experienced the dysfunctions of the current systems, but she's also worked very hard to make some of those changes. And Bob, I thought you were going to kind of help with that conversation. So I'm going to bring both of you back up, and I'm going to sit down, and let's start off with Kay's story.
Thank you very much.
You don't want high chairs?
Well, no, I think it's a little bit hard to sit.
Okay.
We want to be relaxed.
All right.
We're going to be very relaxed. Can you see us and hear us okay?
Yeah.
And
you can tell we're not as scripted as the presidential nomination
oh,
process.
come on.
Yeah,
the balloons are right up there, aren't they?
no rock stars.
No rock stars. Okay. I'd like to introduce Kay Robertson, and I won't go into the details. I'll just say, because she'll probably talk a little bit about that, but she is from Southwest Washington, has been I'll say, has experienced the full spectrum of what our mental health system provides, all the way from her young days as a young kid, all the way through being a family, with homelessness, with a number of other things. And I want to say, just talking to her, she's really inspiring, because she, pulled herself up, and this is a little bit of, I guess, the American dream or American story, pulled herself up, and she's back working, and she's helping other people full time, when she thought at one time she was disabled and dying. And I think this is really a great story. So anyway, as I've taken away her main thunder, we can, I'll go to a question and answer. What we want to do here is just let her have a chance to talk, and we've set up some questions to kind of help that come out in an organized way. But also, one thing about today, I think it's important that we are open to questions and thoughts that people have externally. So we're going to try to give a little bit of time at the end. And oh, you have one, good. Then at time, so you think about if you have questions or thoughts, it would be really helpful. So thank you, Kate, for being here.
Thank you guys for inviting me to come. I appreciate it. I'm very passionate about mental health and physical health, because my voice is hoarse, thank you, because I was on the ventilator for 6 weeks and survived it. But my childhood was one of very much dysfunction, both physical, sexual, and neglect. There was a lot of that. And we were on Medicaid, growing up on welfare, poverty, even before the lunch programs. So there's a lot to say about the different systems of care that we've been through. What's exciting is that going through that, getting married, moving on, having 4 children, 2 of them disabled, 1 of them passing away at age 7, I've experienced a lot of the bumps in the road that you're going to find. And but I survived. And now helping other people. And it's really about how to help navigate. One of the terms I call myself, and people like myself, is system navigators. We help people grab them up, pull them out of the ditch, and pull them along. And so system navigators is kind of what we have decided that if you call them peer counselors, we're not really counselors. We are more people who have been there, done that, and are like cheerleaders on the side, which is what changed my life. Because I was in counseling for 12 years, Medicaid counseling. I had counselors changing constantly, but every 6 to 9 months I'd get a new counselor. So we could really never do anything. I had a really hard time trusting because of my background. So it was a really difficult thing. When I finally got to a point where we got to a faith-based community where they connected somebody with me, because I would wear out churches and pastors, and everybody's just going, oh my God, because I'd call and, I was desperate, and I was a mess. I think they call it borderline, but I was a mess and scary. I would be in emergency rooms all the time. I never went to the doctor regularly because I wasn't taught that as a child. And you have this generational poverty that continues on. And oftentimes, if you find somebody who's a mess, they beget a mess. Dysfunction begets dysfunction. How do you change that? And that's what we're here today for.
Great. Well, tell me, would you just describe, you mentioned peers, how this faith-based and what happened and what was different about that from your other experience in counseling?
They came to me where I was at. I developed sepsis and was bedridden after being on the ventilator for 6 weeks. And they told me I was dying. And I spent most of my time in bed or in a wheelchair. They came to me where I was at, because while I was in the bed, I ended up getting very panicked and couldn't leave the house. And I was a mess. So it got to a point where they came to me And my house was a disaster. He would scoot the stuff off to the side and set his coffee cup down. And what he would tell me is, I believe in you. You're valuable. And I kept telling him, if you really knew who I was, you wouldn't be saying that. And I would share with him, and he would say, but you're valuable. You can become employable. It's like, again, if you knew who I was, but he kept consistently giving me the same message. Then we moved to the point to where we were meeting in a church, because I got, well, I started getting stronger. So he would challenge me to press in and press forward. And I found that, hey, wait a minute, I'm walking with a walker. They told me I was dying, and I'm walking with a walker. And he would point out the different things that I was doing, but he met me where I was at, and he didn't assume that I knew and understood things, because there were certain things I didn't, I had never experienced, you know, like relaxation or safety. And he would teach me boundaries by setting them. You know, in each piece, we met and continued and continued. He would be there for my phone calls. He would be there for my fears, and he kept the message consistent. And he would share with me different experiences that he had. So it was like a peer-to-peer relationship. As a matter of fact, I still have coffee with him once a year. So
that's I think a lot of lessons there. How about other issues such as, we talk about social determinants of health. You probably heard of that, but what are those other things in your life other than medical care and the care for your mental health related issues? What's affected you, and what's the value of those?
I think one of the primary one that comes to mind is homelessness. We became homeless, and the stress of becoming homeless, I became dehydrated because I was just too stressed. I didn't know how to self-care, and you can't self-care when you don't have a place to put your head. And so we were all grouped up in a room. I was blessed. I got shelter. And believe me, there's other people out there that don't even have that. But it's when you don't know what to count on, it's how can you take care of yourself or follow up with appointments? You know, your world is turned around so much. I became so dehydrated that I got hospitalized. They thought I had a stroke. They thought I had meningitis. I mean, it was just, they were not sure what was going on. I was in the hospital for a week over dehydration, just from the stress of being homeless.
Thank you. We talk about ACEs in kids, but it doesn't ever stop, does it? Let's turn to what's happening in Southwest Washington. You followed it from the get-go. What do you see happening, and what are your observations?
I'm excited to be a part of Clark County and a part of the integrative care. These are things that why are we so shocked about a whole health? Kind of like, this is a given. It's not always a given. When I was under mental health care, I didn't see a doctor. I saw my psychiatrist and I saw my counselor, and I rarely went to the doctor. I'd go to the emergency room if I needed something, because that's how I was raised. A lot of times people just say, well, you shouldn't go to the emergency room. Well, that's hard when that's what your expectation is. I don't know how to utilize insurance. One of the things that's really great is we've been reaching out to people with the insurance companies, Molina and Chippewa. I'm not supposed to say that word. Community Health Plan of Washington. Anyway, sorry about that. Anyway, they're reaching out to people that are struggling, that may be going to the emergency room. And I say that's great. That's not enough. I see 60%, and I don't know numbers, I don't know studies, but a huge amount of people are not using their mental insurance. They don't know how. I work on a crisis line, so we do community outreach. And I sit with people all the time that if you ask them when was the last time they got proper health care, or that they've got a medical condition and they're just dealing with it. Well, they deal with it until it becomes an emergency, and then they know where to go. And those are the people that are being missed. You have the people that are being reached out because they're costing a lot of money, but the people that don't understand how to use their medical insurance, those are the people that I think are being missed. They don't understand how to use their mental health care, and they don't know how to use the physical health care. And to combine it confuses the heck out of them. Most of them don't even understand how to deal with the insurance cards. They don't know that they can call. I mean, one of the parts of my job is teaching them how to use that and to sit with them and make phone calls. When you are depressed or anxious or have PTSD or even schizophrenia, making those phone calls is huge, just to get through the buttons that you have to push and try to figure out who you had last talked to, and then to remember the appointment is, it's amazing. It's simple. Like my doctor now, I have private insurance. They text me the day before about my appointment. Why can't community mental health do that just to remind people when it's something that's simply done in the private world? Why can't that be transferred to community mental health?
You mentioned teaching people. What lessons have you learned from reaching out and teaching people?
It is so rewarding being a peer counselor and being able to help people because I know what it feels like to be lost. And so I'm very, very passionate about reaching out to people, teaching them proper boundaries. One of the biggest pieces that I have found is that people don't have friends. They think of their doctors and their counselors as their primary peer support. They don't understand how to have a friend. Again, if you've come from a dysfunctional background, usually your friends are just as messed up as you are, so they aren't very healthy. To have healthy friends is so paramount. I teach a class. I'm starting another one. It's called Recovery 101. And one of the primary things that we talk about is, who is your supporters? And on the very back of the page of 4 pages of the process we go through is your professional supports. I'm not saying they're not important, but I think that it needs to be taken off the table for people because they'll call when they're upset when you would normally call a friend. And you don't reach out, you don't get the response. And so that message is, I'm not important. And it's not the message, the counselor's busy seeing other people. When I explain that to them and explain to them that they need to develop friends, how do you develop a friend? How do you get a friend? Those are all things that are very important to people. And everybody wants a friend. Somebody that cares for them, like the gentleman that sat across the table and met with me one-on-one and was there consistently. You can't pay enough to get somebody to do that. Those are the people that need friends. In Clark County, we have a drop-in center called CVAB. That's where I run the group out of, so that they have to come to the drop-in center so that they can get to know that there are people out there they run there by employing peers. And to me, peer counseling is so important because when you've talked with somebody, when I sit across the table from somebody and I say, they're telling me all the reasons why they can't work. I have this, I have this, I have this. And then I say, well, I have this and I have this and I have this. and I also have, like 15 medications. Oh, you have that medication? Oh, yeah, yeah, oh, yeah. You go back and forth. then it's like, but I work. Oh, you have all of these disabling conditions and you work? And I said, yeah, and I just love it. Oh, you could become a peer. Oh, no, I'm too sick. No. Let me explain how I was. And then I became stronger. And it was classes that taught me the peer support training was helpful to me, just for me. Even if it isn't something, if I wouldn't have gone to work, I learned a lot of how to actively listen, so that I could get listened to. And then I started practicing on everybody. I thought it was cool. How do you actively listen? So anyway, it was a lot of learning and a lot of sharing.
Thank you for that. I wanted to talk a little bit more about the system changes down there. And, obviously what really counts is not just that we may move the things around, but how they affect people. And maybe can you talk about what you've seen, changes, improvements, problems, whatever, that are going on in the new integrated system down there?
There have been some changes. Getting the word out to the common person is still lacking. I think that just getting them to understand that, you guys are all starting to talk about integrative care. Well, the people that get the mail are still trying to figure that out. I think that there needs to be more education on not only about whole health, but just start offering other information and offering it that it's taught by people who've been there, done that. I think there's been some awesome changes as far as, more simply put, being able to integrate by talking to doctors and having the doctors talk. When I would go to the emergency room, I would never tell the emergency room doctors that I was on psychotropic medications. Now that's dangerous. But I was afraid. I was ashamed of my mental illness. And so I wouldn't tell them. I had to learn how to advocate for myself and learn how to share that with doctors. So I think now having people talk is paramount, because not only is it going to affect the patient, it's going to affect the doctors. Because most of the doctors will go, if it's a physician doctor, oh, that's a substance abuse issue, or that's a mental health issue, move on. Or oh, it's a physical issue, move on. Well, they keep moving people around, but they don't ever follow up because it's overwhelming. What would happen if you, say, went to your counselor and they saw you coughing and they helped you make an urgent appointment? Help make that follow through, that step, because you're symptomatic and it's overwhelming, to be able to do those steps. So having that simple help would be very helpful.
And just about, you're working with people who are navigating the system, and they're not as knowledgeable at this point. When you do, are people down there communicating better yet, or are they, what's happening?
Are you talking about peers communicating?
No, I'm thinking about the patients being able to have a more coordinated care. In other words, are the doctors talking to the mental health, substance abuse?
I think it's starting. I see that we're only at the beginning. Primary care is, I think, I've heard feedback from patients that have a lot of problems with primary care, kind of looking at the mental health. If you have the one agency down there that does both, there's feedback that's I've had patients say that they don't really care for that because they get shuffled and they are herded through pretty quickly. And so they'd rather go to the primary care doc that's outside of the, realm. And then the communication needs to be there. I think that on the side of the doctors and the clinics, the communication is starting, but it's going to take a while. Getting them all to the table. What I think would really help is if they were at the table with other consumers, and if you put the doctors and the consumers together, because I don't think the doctors get what the need is. They keep thinking, well, what's the problem? It's like, well, the simple thing is that, having somebody follow up with that person to make sure that they're okay is huge. In private insurance, they do it. So why not treat everybody the same? Why can't you do follow-up care or have somebody help that person? And maybe it's a peer that's working in the mental health field, so that they can help explain to the doctors that if you don't have a place to put your head, you can't go tell a person to go relax and lower their stress level.
Thank you. It's okay if I ask people to ask questions?
Sure.
Anybody have any questions or thoughts or comments they want to make? Over here, please.
Okay, I just want to pick up on the comment
Could you please?
Oh, I'm sorry. My name is Peter Morgan. I'm with the Family Health Centers in Okanagan. I just wanted to pick up on the question, the statement you made that patients often don't want to see behavioral health and clinical care together. And I interpreted that to mean that if behavioral health is provided in as hurried a manner as primary care is, it's not likely to work very well. Is that
Right.
Is that a good interpretation?
Very much.
Okay, thank you.
Thank you. Any other thoughts, questions? Good. Yes. Dorothy?
So I'd be really curious, I'm really struck by your comments about getting the word out in the community better and having conversations really with doctors, peer counselors, people that may need services, and having just more conversation as we're moving forward about how this works and what some of those pieces it's at the beginning and we may be forgetting that there's still a lot of ground to cover in terms of just explaining and dialoguing really about how this new system can work better and how to use it. So you suggested maybe some conversations or some community conversations that would include just a whole mix of people. Have you thought about that any more than how that would look or what your thoughts are further on that?
I know that a lot of the times I believe that doctors, and I could be wrong, I'm still struggling with, who understands what, but it's, I don't know, I think there's an assumption made by people sometimes that, they're going to get it. Well, if they haven't gotten it when they were a child and somebody hasn't taught them when they're an adult, when are they going to get it? There's assumptions and prejudgments made that people have the mental reserves that it takes to get through all the hoops you have to jump through to make a doctor's appointment, get a counseling appointment, keep them all straight, and get the transportation provided to get to all these appointments. Then, of course, there's always the specialists that they throw in on top of them. And how do you keep the specialist's information, carry it over to the primary doctor? And a lot of chronic illness that comes from the medications that you take end up causing you to go to specialists. And so then there's a whole nother level. I think that if you put people in the same room and communicate with them, there'll be a lot less assumptions made that this is happening. I think that keeping everybody on an equal pay, it's like, do you even understand? You're moving forward with change, and we haven't figured out how to actually properly use primary care and mental health in the first place. So.
Thank you. Diane.
Hi, Kay. I'm Diane Sosney, I'm a psychiatric nurse, and I'm with the Service Employees International Union. And thank you so much for sharing your story and walking us through your journey. I'm curious, because you've talked a lot about physicians and counselors, but if nurses played any role in this journey that you've been on, and if so, what have you seen? Or if not, I'd be curious to hear about that too.
I actually had some really great nurses in my life. My psychiatric nurse practitioner had a nurse that helped navigate and teach me some of the ropes on how to get care. I also was blessed with a primary care doctor where the nurses I communicated with more. The more I learned how systems worked, the more I talked to the nurses. Back when I didn't understand who to talk to, I didn't know to talk to the nurses. I think just getting that information out, how do you utilize your insurance in the first place? And the thing is, if you try to teach this with people that have not been in that situation, I think there's a disconnect. But if you get people who've lived in the streets, who've lived those experiences, and have them teach, then they can point the buttons at the real pressure area. You really need to make those appointments. You need to be able to follow through. People a lot of times will honestly make appointments and then not show up. They don't really pay attention to that. That could have been somebody else's appointment. When I talk to people about that on the crisis line, and I say it's really important that you make that appointment because it's going to be difficult to get another appointment. It's going to take longer. And if they've set that time aside for you, all that you normally wouldn't have to mention to someone, you might need to mention to that person, because the feedback I get is thank you. And sometimes I will myself call that person the day before and remind them if something has come up they need to cancel. And they so appreciate that. It's like, oh, thank you. I totally forgot about it. So it avoids a mess.
Thank you. Joe.
Hi, Kay. I'm Joe with, I work for Kids Up Mental Health. And a twofold question. First one is, you mentioned earlier in your story, and I commend you for your courage, because that's what we need to have more of, people coming forward to speak and share their story. But the question is, you mentioned about the stigma interfering with your ability to access services and the stuff like that. Are you aware of any efforts being made to address that issue of stigma, like mental health first aid? Do you know if that stuff is going on?
NAMI.
NAMI is taking the lead?
When I did the family-to-family course with NAMI, it changed my life. I now do a family support meeting, and I use NAMI space for it. And it is amazing that these families, who are often forgotten, I can save a person's housing just by alleviating some stress off a family member. So NAMI has been very instrumental in being able to make those changes.
That's wonderful. That's a great partnership. The second question I have, do you want to talk a little bit more about what you had to go through or to become a peer specialist? Aside from your personal experience, which is more than enough as far as a background and credentials, in my opinion, but then was there any additional training or courses or anything?
Yeah, there's a training that is provided by the state of Washington, and now they do online training. I think it's 5 or 6 hours of online training, and then 40 hours of training just to get some of the basics down, because you want to make sure that people have gotten to a certain level of confidence. And then I think there needs to be more training. When I first became a peer counselor, I came into it with a bunch of therapists that didn't know what to do with me. You know, they'd never been around a peer. Usually you have appointments and we're the ones detaining you, but what are you doing here? You know, so it was a little uncomfortable at first, but to be honest with you, I am so supported by my team, and they have really helped me to blossom into the person that I am. I think that therapists and peer counselors can be a great team. A lot of the times I do some of the running around and following up and checking into and those kind of things that they don't have time for. It doesn't mean that that should go undone. That's what you have the peers for, is because oftentimes they will be more than willing to talk to me, where they're going, if they meet with the therapist, it's the first thing they talk about is their diagnosis. But when I talk to them, I say, I'm not interested in your diagnosis. What's going on? What is your most pressing problem today? And we go from there.
That's great.
Aaron Spark from the Seattle Indian Health Board. Thank you, Kay. Your fortitude really speaks volumes, and so I have a couple of comments in support of what you were talking about. We just recently came back from the Northwest Indian Treatment Center, and they had an amazing model where they have recovery coaches, which is what you do. So they follow them for a year afterwards, and these are people who've been through the program before, and there was a case where the counselor, our certified counselor, or their certified counselor was talking to one particular community member, following up saying, is everything going okay? And every single time the checkup happened, they said yes. But when the peer support counselor called him, and this is a person who had been there, substance use disorder, but he also had suicide ideation issues, and he immediately knew that there was something wrong with him. So he called him up again a second time after having his first conversation and found out that over that 6-month period where he was talking to his counselor, he had attempted 3 times. And he didn't talk to anybody else about that, but that came from peer support. But that position right now, that's only grant funded and through tribal money, so finding that money to be able to do that and the communication with the counselors, that system still has to be bolstered. And we absolutely need it. You hear it here with Kay right now, and then you also heard what happened in Indian Treatment Center. The other piece of that is being able, as we're talking about the integration, how to get the medical staff to be able to talk with the behavioral staff in a very legal way. So this is something that we're trying to figure out. So we have our medical director and our behavioral health director talking to each other, figuring out what is the way that we can communicate with each other without getting in trouble while we're being forced into integration. And at this point, it's not just forced. This is something that we're all doing. This is a national directive. But they're still figuring out how they're supposed to be talking to one another in a way that they're not going to get in trouble with these patients. And then also figuring out how to use peer support, which not always certified, or credentialed while we're going along the way. So there's a lot of work to do, but it's absolutely necessary that we get there. And again, thank you for your story and for your work.
Thank you very much. We're near the end of our time, John, of course. Well, our last question, and then we're...
Hi, Kay. I'm John, and I work in public health, and thank you so much for sharing your story and being with us today. You talked about growing up in a dysfunctional family, abuse, sexual abuse, neglect, the way it sounds. How do you see us working with the family in this sort of new environment? And, if you go back to growing up, what would have been helpful that we should be thinking about when we think about both physical care, mental health, substance abuse, but the services that families need to be healthy?
I know that CPS got involved with my family, and my mom knew just what to say to brush them off. I think that it needs to be support, non-judgmental support. If you're going to change how a person is functioning, it can often be something that's generational. And to be able to do that, being able to, well, this is the experience. When CPS got involved with my mom, nothing happened. When CPS got involved with me later on, they provided me with bus tickets. They provided me with support. They didn't come in and say what a rotten parent I was. They said, look, you've got all this pressure. Let's support you. I took a parenting class. What would have been most helpful is a peer. Maybe another, because when my son, I have a son who is a heroin junkie that travels the circuit. I think he's in Chicago right now. But I know that there was the Connections program in Clark County to juvenile justice. that family, mother, parent, the parent-to-parent role is what started me on the idea of maybe I should check into peer counseling myself. So having that family parent role, another parent who's been there, done that, I really think that, again, I know you guys, I'm saying peer counselor a lot, and I don't want to get you bug out again, but really family support with somebody who's been there.
I want to thank, first of all, I want to say that we've all learned a lot, all of us, from your experience, and I want to say I really appreciate it. I want us all to give her a big thank you. Thank you very much. You know, I'm always humbled by how much I learn listening as opposed to talking. We have the next session, and we're going to have Joe, or Mr. Vanessa, Peter, and Bunk. Is that correct? So you guys come on up. And what this is a panel of people speaking about their experiences so far in Southwest Washington. And Dorothy is going to step in at the end and moderate a discussion, but each of them gets to have a few minutes to talk. Why don't you each get one of these little things here? And so just to invite, everybody probably knows people, but I want to tell you, this is Vanessa Gaston, and she is it's not really true, the community services director for Clark County, and has been a key person in the Southwest Washington conversion. Peter Adler runs Molina Health, and they've been, you're the biggest provider down there, but teamed up with Community Health of Washington, and you're doing a lot of, I understand, a lot of learning in that, and I look forward to hear what you have to say. And Bunk works for Community Services Northwest and is a behavioral health provider and has experience as well. So I'd love each of you to take about 8 minutes. I think that's what they say here. And then Dorothy is going to moderate a discussion. So let's start with Vanessa, then Peter, then Bunk. Go down this way. Okay? Thank you.
Oh, yeah. So good morning. So I'm coming today to speak for the region. So I am the lead person for Southwest Washington, which is Clark County. We represent our county commissioners and our county citizens. My department, I actually manage a lot of the human services for Clark County, but I have been assigned the point person to kind of speak on on behalf of the region. I don't make the decisions by myself. We have a lot of people that are a part of teams that work with us. But I want to kind of talk about what the county's role in all of this is, because for us, our county commissioners for Clark County took the risk and made the brave decision to do early adopter. And so we wouldn't be doing this if it wasn't for those county commissioners. And so when we go forward, I have to make sure that we think about the entire community. So criminal justice system, housing homeless programs, I have to think about employment, I have to think about all of the other things, public health. I have to think about all the systems that the county touches as we move forward with this work. I serve in the role as an advocate. County staff serve as an advocate for people on the services, but also for the providers. We also help to translate a lot of information to people. A lot of allied systems, they do not understand healthcare. They do not understand the acronym. So I am out in the community talking to juvenile justice, talking to educators, talking to children family services or whatever, trying to help them understand the change. We also are funders. We have local funds that we fund. The county is responsible, so we actually fund quite a bit to support the services. And then we also do knowledge transfer. So I was the administrator for Southwest Behavioral Health, and so the county also managed the outpatient substance use disorders. We had to do quite a bit of educating the managed care organizations about the systems and the programs and how to fund the providers. So we had to do a lot of knowledge transfer. So the counties are extremely important in this. And what I would say is what we have learned from this process is you have to constantly educate your elected officials. And I'm not just talking about county commissioners. I was surprised at how much the local legislators didn't understand about this change. So we have to do quite a bit of trying to educate all local officials, to include city council and all of that. So just trying to constantly make sure they understand what's going on and what the changes are. but also learning that you have to be flexible and patient. Change does not come fast, and hopefully that you have managed care organizations that are flexible and patient with you and good collaborators. That's key and important. We also realize that we have to find a role for the county commissioners, okay? So I have some county commissioners who are very much involved and care about what happens to this population. And when you do full integration, you know, the risk goes back to the state, and then they work with the managed care plans through contracts. And I have county commissioners saying, well, people come to me though, and you know, how do I stay in touch? So I'm gonna have to work with healthcare authority to help keep those county commissioners engaged, because they do care about this process. And so as other regions come on, they're also, county commissioners are asking, what's our role in all of this? So that's one of the learning lessons, is you can't forget about those local elected officials. And then I would also say another learning lesson, primary care, it takes a lot for primary care to come on board and look differently at this population and want to serve the population. So there's some education that has to happen about training primary care about how to work with people with behavioral health disorders. And then please don't forget about substance use disorders. I mean, I heard a lot of conversations about mental health, but that is key. That's key. It impacts quite a bit of systems. There's a lot of people with co-occurring disorders. So it's not just about mental health and physical health. You have to think about substance. You got to talk about dental, got to talk about long-term care. So unfortunately, we're not doing all of that in our region, but eventually we will get there. And then I would also say you have to spend some time, investments with your behavioral health providers. That is the most disruptive change is going to happen is with your mental health and substance use disorders. You got to put some time and some money in there to help them move to getting that change in there and do what you need to do. And Bronco will probably talk about this. Don't try to do it all at once. You know, our providers asked us to do financial integration first, then phase in clinical integration, because it's just too much. It is just a huge change for them. It's a administrative change, it's a clinical change, but it's a philosophical change. And so change is hard. You've got to work with your providers as you kind of go through this. So I just wanted to kind of share some successes we've seen. We've brought housing providers to the table. I've got appointments next week where they are now saying, let's do some more projects where we work with the behavioral system. So our housing and homeless providers are excited. They are saying, finally, we've been serving this population. We need to work with healthcare on how to make sure they get access to treatment. So you got other systems, juvenile justice, finally, you know, how we need to get people into this. So there are other allied systems who are saying we need to bring people to the table and figure out how do we work together. We got some interesting pilots going on around in our community. So we're looking at our housing authority, looking at building some housing for people with behavioral health disorders, and our treatment providers, Bunk is one of them, that will be located, some services on the first floor, working with Lifeline Connections as well. So that's new for us because those systems have never worked that way together. And then I would also say I'm just also excited the fact that our community bought into this change. It's not easy, but our community is on. And so when there's things that need to be, they're quick to come around and find quick solutions. And I would say that is don't place blame, focus on solutions. Otherwise, you're wasting time. So that's kind of what the comments I have from the county perspective.
Thank you, Vanessa. I think Barack Obama would say, don't boo, vote. I'm Peter Adler, and I have the pleasure of leading Molina in this journey. And I want to begin with, this is an update that is 4 months old. And so, Kay, so much of what you talked about so eloquently and with your heart is the light that's for all of us which is beginning to be shined and shown upon a system that has been so fragmented for so many years. There isn't one of us in this room or in Southwest Washington who today, I would say, even after 4 months, fully knows everything that we don't know. And so this is really a journey of both humility and a lot of hope for us. So from Molina Healthcare's perspective, the integration, we talk about it as if it's one word, one event. And for Molina, we very quickly realized that's so oversimplistic. Integration needs to happen at the level of the medical and behavioral health systems, at the level of care delivery and integrating care delivery, and we certainly are all aware when that doesn't happen. And critical to this, and KU spoke to this so directly, at the level of care coordination and the integration of the coordination of care. Integration needs, at a minimum, to happen at all three of these levels. We, okay, next slide. Today, or going into this, and certainly the existing current state, as we all know, that both the financing and the care delivery are not integrated. And to Vanessa's point, chemical dependency is its own world that needs its own amount of intention, and cannot be just lumped wholesale into behavioral health or mental health. The integration of financing and the goal of integrated care delivery, it's, as you can see on the right side there, where physical health, behavioral health, chemical dependency lead to integrated services coordination. Financing does not equal integration of care delivery and care coordination. And we know this, we knew this going in, and 4 months in, too much focus on the dollars and the financial integration does not lead to fixing the system. However, it is an enabler. It is, and I'll share an example in one moment. It's necessary, but not sufficient. So next slide. As we launched on April 1st, just 4 months ago, Melina made a commitment to the behavioral health community and picking up on Vanessa's comments, knowing that changing everything at once was and would be a recipe for disaster. Our commitment was that we would begin day one, which we did with 100% of the identical behavioral health network that had been contracting with the RSN would be a part of the system, because most important to us was that we didn't break continuity of care in terms of care provision. And we succeeded in that. We feel very good about the fact that 100% of the behavioral health network and chemical dependency network that was working with the RSN previously was working with Melina day one. Assuring access early on from day one for authorizations and payment. One of the things that we are still learning today, literally today, is that the behavioral health community, the chemical dependence provider community, financially is a much more fragile community financially than the physical health community. That a delay in payment of not just 30 days or 15 days, but 24 hours can mean the difference between a behavioral health provider, an excellent behavioral health provider, making payroll and not. And so we have taken that to heart, but we are still learning that this is a very different caregiving community in terms in how it differs from the physical health community. The integration of I'm going to back up for a moment. Collaboration of standard processes. I'm obviously here to speak from Melina's perspective, but CHPW has been a remarkable partner with us in this as well. We've made a commitment to the community and to the healthcare authority, not because we were asked, but because we saw early on that what we need to do as the managed care organizations is standardize our administrative processes, our referral processes, our all the administrivia that goes along with the provision, the funding of care and provision of care. And so CHPW and Melina have partnered to standardize and simplify all of that. So we're not there yet after 4 months, but we've made huge progress on that. We've both opened local offices and embedded our care teams in the community, which has made a huge difference, so that the managed care organizations aren't visitors to a community or sitting outside the community, but have become part of it. Some early success stories, which was the request in the 7 minutes here. The I'd say the leadership from the community and all of the components of this fabric in Southwest Washington has been just truly amazing. And Teresita, you said there aren't rock stars here, but actually there are rock stars in this scenario. Two of them are up here with me. But there has been leadership. This is not a change process we've learned in our 4 months that will work unless every part of the community that's involved takes a leadership role. There isn't a cookie cutter or an easy answer. It's been terrific. There's an early warning system and metrics that have been co-developed with Healthcare Authority, with the SHS, and with the counties. And we monitor that every day, every week. And thus far, the good news after only 4 months is that nothing has broken that was already in place. Ironically, so much of everything we've been talking about that with all of the breaches in continuity and the lack of communication, that was what the status quo was. But the early warning system has been working and has given us all very good feedback. I've talked about the remarkable levels of collaboration that have also been necessary. Vanessa talked about that as well, between and among the providers of services and care, and inclusive of those service providers for social determinants of care, housing, food, transportation, etc. So I want to end in my 7 minutes with a member story. And Joe, I'm going to pick right up on the story that you shared, where when coordination doesn't happen and fragmentation exists, people don't just get lost, they die. And I want to share a true story, one of many from Southwest Washington, a Molina member, that I think we reached a different outcome as a result of the integration. So I'm sorry, I had one more slide. I was jumping to my landing and I landed too quickly. Quick short-term achievements, other things. I've talked about the first one, the continuation of continuity of care and replicating the behavioral health and crisis service networks from day one. Our ongoing work to ensure that there aren't administrative delays in getting payments made to providers. We're still working on that one, not where exactly we want it to be. Care coordination began on day one, and I'm going to share that in the story in a moment. No wrong door for entry into the system. The elimination of access to care standards has been a huge benefit. The feedback we get from the behavioral health community and the chemical dependency community, but for all of us to eliminate that step and that care coordination can begin through any door has been a huge early success. Increased access to primary care for behavioral health providers. Kay, you touched on that. You couldn't have said that more beautifully. We talked a lot going into this from the other end, that we need to make sure that primary care providers were talking to behavioral health providers and had access to behavioral health. It's also the other way around, and we've had some very big improvements in Southwest Washington. Not, again, in 4 months, not where we ultimately need to be, but are headed in the right direction. There are integrated case conferences happening multiple times around multiple members every day now that involve the behavioral health, the chemical dependency communities, the juvenile justice, depending on the person involved, the health plans, primary care, that we are beginning to convene, and I'll share this in the story in a moment. In 4 months, we've had a few transitions, a few members who were in Western State Hospital at the time on April 1st when the integration began, and we've had to the person the transitions of those members, those individuals, when they were ready to be discharged. We've had very successful transitions. And then the final thing, and this came up, I think, in all of the prior comments, the need for information for caregivers, whoever they are in the moment, whether it's the chemical dependency provider, whether it's the emergency room provider, whether it's fill in the blank. And Molina has launched a personal portable health record a month ago now, which is being populated for every member in Southwest Washington, that will contain information about medications, psychotropics and others that a person is on, and other key information that is HIPAA compliant, that's accessible to any provider who is involved in the ecosystem caring for that person, and the case managers as well. The member also has access to their own portable personal health record. Big surprise, we're calling it My Molina, but we're very excited about, once this is fully populated, that there will be an ecosystem of information that's accessible at whenever it's needed by the people who need it. The story that I want to share is named here, and picture obviously are surrogates. But this is a true story. This is a real story, and one of many that Molina has encountered in the last few months. Janice, 27 years old, resides in Southwest Washington, multiple diagnoses, behavioral health and mental health diagnoses, asthma, chronic pain, and is legally blind. Her primary care at the time that she started with Molina, her two primary care providers had stopped seeing her, had refused to see her for the very scenario, Kay, that you mentioned, that they said, just too complex, you're not compliant with coming to appointments. Appointments are taking 40 minutes, and you have conditions that we just don't know how to deal with. That was the reality. Janice, in the year prior to joining Molina in the integrated environment and becoming an integrated member, had 140 ER visits in the prior year. So the physical health system was very happy to welcome her. She was known at the emergency room 140 times. In addition, multiple hospital admissions for her. That was the profile. And Joe, I would suggest, when we met Janice, when she came to Molina with that profile from the prior year, that without intervention, we don't think Janice would be here today. In an integrated environment, our care coordinator and our community connector went to Janice's home, spent time with her, and then went back to the primary care community and negotiated on Janice's behalf to, in fact, reintegrate her in their panel. And the condition that we agreed to, if you will, but this is what it's taking on a member by member, person by person basis, is that our care coordinator or our community connected will accompany her to every visit. And we have every time now. Our care coordinator calls Janice every morning at 8:30. They have a date. But the results are that, we also have arranged through an interdisciplinary care conference that has happened now multiple times around Janice's care with the behavioral health providers and the physical health providers. And Molina, she's now enrolled in a pain management program. She has made every primary care visit in April. So her run rate was 20 to 22 ER visits a month prior to this. In the first month in April, there were only 8 ER visits. In May and June, there was only 1 ER visit. In July, there were no ER visits. There has not been 1 medical admission in the hospital since April 1st. This is one story. There are over 100,000 fully integrated members or Medicaid eligible people that CHPW and Molina are responsible now in an integrated environment for coordinating. But we think we're making a difference with that. So with that, I want to now turn this over to Joe Bunk. I'm sorry, not Joe. Looking at Joe.
I was thinking about Joe too. So.
Were you?
Yeah, I was.
I was too. Looking at him. So Bunk, the world from a behavioral health provider perspective.
Thank you, Peter. So I think I'm going to start with a success story because one popped into my mind. But just first a bit about our organization for any direct service organizations that are out there who are wondering what lens we're approaching this from. We're a behavioral health organization that has about 100 employees, about a $8 million budget, 4 clinic sites, a lot of community-based staff. We do outpatient substance abuse treatment, outpatient mental health treatment. We also have a housing department that has HUD programs, local state programs that have subsidies and support services, plus we own units, so we're actually a landlord with 13 units. So that's sort of the lens with which our agency is looking at and experiencing this transition. And we have a PAC team, which is my success story. Good segue, Vanessa. So the success story, and this is, I started my career in this field on an ACT team. I was a case manager. I was hired in 2004 at our agency and worked in that model for a long time. And one of the challenges we always had was getting individuals who were coming out of jail, coming out of Western State Hospital, coming out of inpatient, who had an established primary care regimen in place, scripts, things that required blood draws, things like that needed attention very quickly. Getting them connected to a primary care provider once they exited that system was always a challenge. We had identified this problem after April 1 with the health plans and described it, gave them some specific examples. And within a week, we had upper level management down talking to our ACT team. They gave us a new list of contacts, a way to who to approach at the clinics to get this stuff sorted out, and we haven't had a problem since. So for whatever reason, everybody's well-intended efforts prior to April 1, that was never happening. After April 1, it was resolved very quickly. And I think that's probably a microcosm of the global changes we'll see in the coming months or years, more system-wide. And I know that it gave the nurses on our ACT team a lot of relief because the pressure was falling on them to be the primary care by proxy because they're medical professionals and they've got people with medical needs. So I got a lot of smiles from my direct service staff, which is always nice to get. So that's a success story. I also wanted to mention some lessons learned listening to Peter and Vanessa talk. And going back to 18 months ago, whenever we started talking about this, and I would look at Vanessa like, Vanessa, why are you doing this? You know, this stuff is hard enough. Are you serious? You really want to volunteer to do this 4 years early? So I think back where I was at that time and where the providers were at that time, and we got a lot of technical assistance and training from consultants about how this has worked in other parts of the state or other parts of the country, where it's worked well, where it hasn't worked well, the kind of things that have happened. And people were jittery. They were really nervous. There was a lot of doomsday scenarios. And, you know, I think a part of that is healthy. You know, if you're not nervous, you're probably walking into an ambush, so to speak. And I think that informed us to engage the plans in a certain way. But now I fast forward to today, and it's like I can't even remember the mindset that I had then because I think the leadership has been so strong locally, the buy-in that both Peter and Vanessa have mentioned at the county level with the plans, that none of that stuff has happened. I mean, there's been some small hiccups with payment and all that, but that's the kind of stuff you probably can't avoid with a transition like this. But access wasn't impacted. Jail census hasn't gone through the roof. There's not an increase in homelessness. We're not seeing an increase in complaints and grievances. None of that stuff has happened. And we are starting to see the small successes of having more direct relationships with a payer that pays for the whole healthcare picture. So I'm very optimistic, and that's coming from somebody who was very healthily skeptical 18 months ago. So I wanted to point that out. So I think the right plans, not that the other plans who were in the picture weren't good ones, but we definitely have 2 good plans that are very bought in and collaborative and take feedback and have been very responsive to provider suggestions, provider requests. So that's been key. And like I mentioned, the local leadership sort of raising issues and making sure, hey, do not forget about this, do not forget about that, has been key as well. So I covered a little bit of the doomsday stuff there. Another thing that if you're a direct service provider, I know a lot of people worried about this, the provider credentialing landscape outside of the DBHR provider network is very different. There's codes and credentials that were new to the MCOs. There were service things that we did that we were accustomed, our whole system was designed around and raised a lot of anxiety. Is, are they going to pay for this person to do this? How are they going to pay for that? Cost reimbursement, fee for service, all this sort of stuff. And one of the big successes in the transition is that all of that remained intact. Every single credential type that we have is allowed to submit the encounters they were allowed to submit before and reimbursed in the way that they were reimbursed before. Now all that's subject to change as we try to improve things, but I think the key is that there wasn't this like all of a sudden in one day a third of your workforce is irrelevant or has to bill incident 2, that type of a thing, or needs to take a pay cut. So none of that happened. And I think that was a huge success. And I know it was a lot of work for the plans because they were like, who is this person and what do they do? Can you send us the codes for that? So I mentioned some of the immediate noticeable changes. One of the really encouraging things, and Vanessa alluded to this, is both of the plans have already been at the table around housing. Housing is all over the West Coast is a crisis in the cities. It's certainly an issue in Southwest Washington, and just having the plans at the table, not only clearly understanding what the problem is, but bought into playing an active role in helping us to be in a position to do a better job of supporting housing. So that's really encouraging, and that's something providers have noticed in the behavioral health sector, but also, as Vanessa mentioned, housing-only providers or more social service type agencies have been really excited about. I've gotten a lot of feedback about that. And then, again, for those of you who have direct service agencies, the clinic or the administrative burden on our clinical staff, direct service people, has actually gone down since April 1. And everybody knows that paperwork is an issue in healthcare in general, no matter where you work, what you do. It's a big issue. To see that actually go down with a transition like this at the direct service level is kind of a cool thing, because you talk at your staff about all this big picture stuff and they're kind of like, okay, I got a session I got to go to. They don't remember any of it, and how could they? But then when like an administrative step goes away, then they go, how did that happen? What was that stuff I was talking about? And they're like, okay, we like it. Good stuff. So the more of that we can do, the better, in my mind. And then just a couple of the pain points, because I don't want to sugarcoat this too much. I mean, there certainly are pain points in any transition. Some of the pain points that I've noted down here, talking with the health plans about the changes, it really was like talking 2 different languages. And that took a tremendous amount of time to sift through all the details. And your administrative people at your organization, nonprofit, predominantly Medicaid type providers are very lean administratively. They have to be. So your billing lead is also your EHR super user, is also your compliance officer. So if that person has to engage, 3 health plans on how to pay differently, how to submit encounters differently, then go back and change your EHR to do that in your billing software. It takes a lot of time at the administrative level to implement that. And I'm sure the same is true on the health plan side, to change everything that they're doing so that their systems can accept this stuff. And that was definitely a pain point. I think it worked out well, but it was a big challenge and a big stressor internally. some of the things that came up that were questions that were like, oh, we didn't expect this, it took a while to resolve it, were things like interpreter services. I know UAs came up at one point where it was like just not a different understanding of how those were going to be handled. So I would anticipate little things like that. You can't see everything, but little things like that did happen. They did get attention very quickly. The Healthcare Authority was great at having daily calls for the first 6 weeks, 2 months, something like that, to have these issues come to the surface and be addressed quickly. So that was a great support that was provided at the top level. And then just one other note of caution, the final thing here. The way that the Southwest Washington Mental Health Network was set up, it was a centralized electronic health record that the contract was held by the RSN. And that's good or bad depending on what perspective you want to have, but in a transition like this, if you have a system where anything like that is centralized, that's definitely going to be a pain point. You know, in our case, the vendor doesn't have we don't have a direct contract with the vendor. Limits your ability to have leverage to negotiate how that's going to work in the transition. A lot of unknowns. Payment can change with a new contract. So that's a significant thing to consider if you're looking at a mid-adopter or something like that. Thinking about what electronic health records providers are using, or if any systems are centralized with a BHO, that's something to definitely consider and way in advance of the transition. So I think that's all I have, other than if I was a rock star, I'd be playing the cowbell. So I just want to make that clear in this, and that's all I have.
So to get us back on time, I think we're going to just do any burning comments or questions, and then we'll take a break. And when we come back, we're going to do our introductions. And the question you need to answer when you get introduced, so you have some time to think about this, is if you were a rock star, what role would you play? If you were in a rock star band, what role would you be playing? Okay, Hugh, you've got the floor.
Hugh Straley from the BRE, and thank you for demonstrating the integration and begun with Kay's journey. I assume in the hierarchy of needs, and we always talk about social determinants, that there are two things, and Kay mentioned, that helped her get to the next level. One is housing, stable housing, not shelter, but that helps, but stable housing. And the other is a friend or a care coordinator or a navigator or somebody that will be continuously engaged with the family or the individual. It seems that those two things were really essential, because the navigator in helped you understand that you are capable and got you services that were where you were, that you needed. And I'm wondering, is that, and that housing, because I've been engaged with homeless youth for 20 years, and always it is that housing is the most important thing for, to get the kids to the next level. And if the governor's office wants to know about healthcare and how we integrate, it seems to me that the thing that you mentioned, our housing crisis and access to friends, coordinators, peer evaluators would be the two most important things that we can do to at least stabilize the system so that individuals can then begin to access all kinds of services. Am I right? Are those, and
so one of the successes with this is, I'm glad you brought up housing, is that the issue with the population, and it becomes in our point in time count that we do every year, is that we are finding people with chronic mental health and substance use disorders cannot find housing. So they're on the street. They're not even in the shelters. So when we started this conversation, I had already started going to our housing developers and started saying, we got to do something different. The fact that we did integration freed up my local behavioral health funds so that I can actually use that to support housing programs while we work with them to do treatment. And we're jointly funding stuff like behavioral health specialists that can be on the site at the housing programs. But we couldn't have done that if we didn't do this.
But, it makes also medical sense. It makes medical sense to invest in housing. So where are the health plans? Where's government? Where's the healthcare authority? You know, in creating the resource so that more housing can be developed. I mean, to me, it is one of the most critical issues, and it has a huge impact on the health of our communities.
I can take a shot at that. I think legislatively there's the Medicaid waiver, which is coming, the 1115 waiver, which could provide funding so that supported housing is a insurance reimbursable service. So it's a healthcare service. So people here at the Healthcare Authority could probably talk more about where that's at, but I think it's imminent. So that's encouraging. The other thing is locally in Southwest Washington, the brick and mortar entities like the Vancouver Housing Authority that builds units that are designated for X, Y, and Z, they've told us for years, we'll build. You don't have a problem building. The problem is when you build it and then you put certain individuals in there and the right supports aren't in place, the stuff that comes on their end with damages and complaints from other tenants and all that is unmanageable. I think the conversations we're having now are getting to the heart of that where they haven't been previously. So the brick and mortar stuff can be done locally, or a lot of it. It's, I think, the plan's role, the county's role, the provider's role to collaborate on how we support those entities.
That coordinator, that counselor that also will help once housing is available so that they can access services. It has to be integrated as this spotlight is trying to show.
Right. So, and I'm going to take us to a break now. And I know, Peter, did you have one sentence you wanted to say?
That's okay. I don't want to stand in front of people's break, but I did want to respond.
Okay, why don't you do that? And then I wanted to key really quickly on something Vanessa said that we may have missed in the kind of the part of this that's, if we do it right, is kind of a really cool part. So go ahead.
The two pieces that the waiver, at least from our perspective as a health plan, doesn't go far enough is long-term care support services and oral health services are absent in terms of where many other states have already gone in terms of integrating funding that is much more inclusive on a permanent basis. And I believe, and Melina's going to continue to push on a public policy level and on the waiver level, that we need to go beyond talking about behavioral health, chemical dependency, physical health, and need to include housing and oral health. So truly there is that whole piece. Not the only answer to it, but I think there's an ecosystem that needs to be created that would be an accelerant to exactly what you're saying.
So, okay, thank you very much. And I think maybe at a different time we can actually talk about the intention of the waiver, not that I think dental is a huge problem, but how it fits in with housing and long-term care, which are part of that waiver. But I wanted to just, before we end this, kind of pull together a couple of points. One was Peter's comment that the financial integration is necessary but not sufficient. Without that, we can't continue to open up these doors and now start to feel confident that we can address a housing issue, and you start seeing those connections because we've done that, and that's in fact opened up the world of care delivery in a different way. But one thing that Vanessa said that actually I learned from her when I went down there a couple of weeks ago, several counties in our state have a 0.1% it's a sales tax that can be applied to mental health services fundamentally. Those dollars right now are being able to be shifted within Clark County. You can correct me if I'm wrong, but this is what I think I learned. Because we've integrated the financing of physical health and behavioral health for the Medicaid population in Clark County, the dollars that were used before with that 0.1% to really supplement funding for services can now be freed up to look at things like housing. So it's this really wonderful ability to free up dollars to take them to the next level, to your point, Hugh, which is now we begin to understand the role of peer counseling and supports as well as housing. So it's every time you turn the crank, and we're doing it towards this bigger vision, you can begin to see how that can work. So I'm going to stop us here and take a break. When we come back, We don't really have to do the rock star band thing, but it'd be kind of fun. We will do introductions though, and then go on from there. 10 minutes and we'll be back. Okay, we're going to get started in 2 minutes. If everybody could find their seats, please. 2 minutes. We're going to get started in 2 minutes. If everybody could find their seats.
If Graydon Andrus is here, if you could come to the front, that would be wonderful. Graydon Andrus.
Okay, we're going to get started, folks. Right now, please find your seats. You're not listening. Yeah, you're not listening. Okay, we're going to get started here. My friend Peter Adler just reminded me. That we should have way longer breaks because that's what's the most important part of these meetings. So note taken for that. So we are going to go, in particular, I wanted to recognize Representative Joe Schmick, who's here today. He has been a just tireless partner over the last several months with us at the Healthcare Authority and with others to really try to learn how all this works together. And as I saw him sitting here, I went, oh, not only didn't we recognize Joe, we also didn't go around and do table introductions. So I think we are going to do that. Everybody knows Kay. I'm Dorothy Teeter. Nicole, do you want to go? And then we'll go table by table. And looks like we've got some mics to pass around.
Hi, I'm Nicole Bell. I'm the Executive Director of the Canby Grove. Thanks for being here today.
I'm Peter Morgan. I'm with Family Health Centers in Okanagan.
Be a drummer.
Good morning. I'm Jill Sells. I'm a pediatrician with Reach Out and Read, but really looking at systems related to early childhood. Hello, I'm David Wertheimer from the Bill and Melinda Gates Foundation.
Hello, I'm Aaron Spark, Government Affairs Officer with the Seattle Indian Health Board.
And I'm Regina Delahunt. I'm the Public Health Director for Whatcom County.
Hi, I'm Diana Burkett-Rocco from Group Health.
Good morning, Nancy Gento from the Washington Health Alliance.
Good morning, Vin Fidenko with Choice Regional Health Network and also the Cascade Pacific Action Alliance.
And I'm Representative Schmick. I represent the 9th District.
Janet Varon, Northwest Health Law Advocates.
Jürgen Onosera, Chair of the Psychiatry Department at UW.
Nathan Johnson, Healthcare Authority. Dan Newell, OSPI.
Pam McEwen, Washington Health Benefit Exchange.
Preston Simmons, Providence Health and Services.
Elia Moore, Olympic Community of Health. It's one of the accountable communities of health.
Graydon Andrus, DESC, also known as Downtown Emergency Service Center.
Hugh Straley, the Dr. Robert Bree Collaborative.
John Weisman, Department of Health.
Diane Narasaki, Asian Counseling and Referral Service.
Joe Rozak, Kids at Mental Health.
Teresita Batayola, International Community Health Services.
Diane Sosney, SEIU Healthcare, 1199 Northwest.
Peter Adler, Molina Healthcare.
Okay. Normally I know we introduce everyone that's in the audience as well, but I think well, let's do it. It's always good to know who else here. Forget the interest of time thing.
Hi, I'm Isabel Jones. I'm Medicaid Integration Project Manager at the Healthcare Authority.
Paul Gruen, Bree Collaborative.
Maria Corrigan, Department of Health.
Caitlin Safford, AmeriGroup.
Tori Kanda, AmeriGroup.
Laura Lee, Molina Healthcare.
Scott Platt, Group Health.
Susie Dade, vocalist for the Washington Health Alliance.
Jack Thompson, UW School of Public Health, and also Cedar River Group. And I played a gut bucket in a jug band once.
I'm Joanna Dunham, Programs Manager with the YWCA Health Access Department.
Brian Sandoval, Yakima Valley Farm Workers Clinic, and WACMIC.
Stevie Bradshaw, Community Health Plan of Washington.
Julie Youngblood, Coordinated Care.
Alice Lind, Healthcare Authority, one of the data backup singers.
Howard Springer from Cope Health Solutions.
Jeff Bassick, Independent Contractor.
Larry Lee, a visitor from Southern California.
Glenn Puckett, Washington Dental Service Foundation, and backup singer.
Peggy Evans with Qualis Health.
Christine Stolle, Department of Health. Is dance an option? Sybil Hippolyte, SEIU Healthcare, 1199 Northwest.
Gina Morgan, King County ACH, and Seattle King County Public Health.
Julie Lindbergh, Molina Healthcare. Mela Winston, United Healthcare, and I do play cello in a band.
Matt Helder, House Republican Staff, air guitar.
Okay, and there's Megan's back there.
Megan Oskowitz, Healthcare Authority.
Stella Chang, Healthcare Authority.
Oh, sorry. You're hiding in the corner.
Sorry, I was hiding. Bunk Moore, Community Services Northwest.
Okay, and then let's just start quickly our team up here.
Mary Beth Brown, Department of Health.
Laura Kate Zeichikin, Healthcare Authority.
Doug Conrad, University of Washington State Innovation Model Evaluation Team.
Mark Hartenstein, Failsafe Health.
Kirsta Gwen, Healthcare Authority.
I'm Melina Nashan from the Healthcare Authority.
Okay, great. I think we've got everyone that, and I think we've got more than enough for 2 or 3 different bands with dancers, singers, whatever else we want to do. So to not put too fine a point on it, that's what we're going to need keeping on going here. So appreciate everybody participating not only with their hearts, but their minds and also their musical skills and vision as they go forward. Okay, I am going to turn this over to Joe. He is going to invite a couple of other folks up, and this is the section we've done consumer and we've done payment and finance, and now we're moving into care delivery. Hopefully by the end we'll see how all these parts move together. So Joe.
Tricky, turned it off. Okay, I can take a hint. Okay, so I got 5 minutes. First of all, before I invite my colleagues up, I'm going to give you a quick overview of the state and integration, what's going on. I'm going to do it under 5 minutes. I notice you happen to have one of those things called a watch. Can I give this to you, and when it goes to 5 minutes, can you just kind of like hold it up so I know that I'm at 5 minutes? And then if I go beyond 5 minutes, you go like this, okay? You raise it over your head, and then the rest of the world knows that I'm behind schedule. PowerPoint, go. PowerPoint, next one. Okay, so this is an example of where we stand right now with integration. Each one of these talks about other entity, another health entity has co-located primary care practitioners at the community mental health agency. Or the CMHC has co-located a behavioral health specialist at a primary clinic. You'll know that accounts for about 87% of the respondees, if I add them together, that we do this. This is essentially what's known as, I don't have a light, so you have to do with my shadow, is what you call bi-directional care, where we do care, they do care, and we share care together, all right? So we work cooperatively. This is where the CMHE employs a primary care person that we could do and take on. It's a challenging thing to do. Trust me, we looked at it, but then you have to try to do the integration into the full primary care and physical and specialist healthcare network. It's just, it drops. It's too heavy of a lift, and so on. So anyway, so then you got the CMHA as part of a larger integrated care. Next slide. So moving on is just like, how long have these programs been in place? So the story I shared with you earlier about the woman who came in and then we found her the following Tuesday was from 5 years ago. That was my epiphany. Before that, I was getting notes of come across my desk saying Rocky or Matilda, one of the individuals who use our services, had stage 4 cancer. We were going to know they had cancer until it got stage 4 because we didn't have any health care going on. Nobody was checking them out. So bottom line is in the following 4 to 6 months, maybe 8 months later, I got another note saying that Joe or Matilda or Rocky had passed away. That's the only notices I had regarding their cancer care. Now, because we have located primary care services on campus, we've already identified 3-4 cases, stage 1 cancer. These people are going to live. I don't have to wait for stage 4 to be notified anymore. That is really cool. So anyways, the point here simply is that it's been a genesis that's been building on for quite a few of us that have been, as a matter of fact, over 50, close to 50% of us in this representative sample from across the state have been working on integrative services. Next slide. Okay, so wow, that one looks kind of cool. So what kind of services do we provide at this? So we have, pharmacy and med management are critical services, and understandably you'll see, unfortunately our slide didn't quite work it out. But anyways, 94% go into med management, and then also for physical health, we have, that's actually coming at 94% as well. And then also, if we go into care management, these are the type of services that are being presented at the integrated system, the integrated behavioral health system. Next slide. Okay, so continuing on those services, we have, I get to do it the old-fashioned way too here, kind of keep up with you guys. But the mental health consultation to a primary care facility. So it surprises a lot of people, but 87% of us actually now do bridge over to primary care and have been doing that, as I shared with you. And then also the routing of patient data and wellness programs. The routing of primary care data the exchange of data, 75% of us are doing that. And then you get into wellness programs for people who use our services, and also substance use disorder treatment services, as well as substance use services for people that are comorbid, that co-occurring disorders, which at one time, when we used to say co-occurring, it used to just mean mentally ill and chemical dependency. Now, when I say co-occurring, it actually means, guess what? It could mean diabetes, it could mean chronic hypertension, it can mean all kind of obesity, all kinds of other things are co-occurring rather than just substance abuse. Next slide. Did we get there? Are we there? Oh, barriers, yes, yes. Barriers, what is so the regulatory barriers, 60% of us are saying, you know, licensing, accreditation, reporting, like that, just kind of stubs our toes in more ways than one. Legal barriers are there, but they're not identified as a major restriction. Financial, the reimbursement structure, yeah, that's what we're here to talk about today, right? That's the whole reason why you're here today. That's why we've been meeting and why we're moving forward. Workforce barriers, huge, huge, because basically with the ACA, our workforce evaporated and we're essentially robbing from Peter to pay Paul for our workforce to work. It's a huge, huge issue. Thank you. It's not over your head yet, so I know. Okay, so then the infrastructure. Oh, okay, so infrastructure and all that. Next slide. Okay, next slide. So these are the people, just to let you know, like everything from Navos to Willapa Behavioral Health, real small little place, Palouse River Counseling, multi-care, all these different folks participate in it. Next slide. Okay, so this is just I kind of give you, Jürgen's going to say, oh my God, but this is in my 6th grade, because I'm a CEO, so that's beyond 6th grade level, okay? So we have primary care providers who actually now have behavioral health services like a psychiatrist or psychologists and social workers that work through the impact model, and they get telephonic support for their services. And then if they want to make a referral over to us, there's the community behavioral health services. Our funding is through the BHO. Their funding is through the managed care. Next slide. Okay, this is a bidirectional co-location model currently as it exists. And so what you have here is primary care provider is on our campus and works with our electronic records and we with theirs. We put a behavioral health professional out in the primary care providers. They get paid by the MCOs. We get paid by the BHO. All right? So that's the world, and that's the way it's functioning right now. And the services, what wasn't mentioned is like dentistry. That's something that's new that we're doing that others will be doing, I'm sure, shortly. Next slide. And this is the goal of the integration, is to have the MCOs do fund all of this underneath one umbrella. Okay? Sorry about the overtime. So now with that, I'd like to call up Jürgen, Dr. Unser, and then also John. So Jürgen, I'm going to turn it over to you, please.
Very good. All right. So I'm definitely not a rock star because I'm up here with notes, no slides, very goofy. And I'm going to start by saying that I'm a psychiatrist. I have spent about 25 years working with individuals like Kay, and that's been a very humbling journey for me because I think I've learned in spades, you know, how little I can really do to make people's lives better. But I've also learned that we can accomplish an enormous amount if we work together. And that's why I'm excited about integration. If you think about our delivery system right now in the state of Washington, 3 out of 10 Medicaid recipients who have a diagnosed mental health or substance abuse condition get services from what used to be the RSN, now BHO, from some mental health professional, somebody like me, in any given year. That's 3 out of 10. If you add in all of our colleagues in primary care, it's 5 out of 10. So about 5 out of 10 people who live with a diagnosable disorder get any kind of services at all. So if this was cancer, how would we feel about that? How would we like that only 50% of people with cancer get any kind of services at all? And so why is that? Well, we have lots of challenges, right? We have a huge mental health workforce shortage, but we'll never we'll never work our way out of that by training more people like me. We have to make sure that everybody in the healthcare system, everybody who works in community-based social services becomes a little bit of a mental health provider. That's my bias, and that's sort of been my goal. Some of us a little bit more than others. And it's also not helpful to have access to care standards. I think that's why I was very happy to hear you guys saying one of the first things you did in Clark County, you took those off the table. Because if you're going to say you have a problem, but I can't really give you care except for under these really complicated circumstances, that just creates another barrier. That's not going to help, and that's going to become a very expensive barrier because you're not going to get care, and eventually you're going to be in a jail or in a hospital or at Western State Hospital, and then we're going to give you lots of expensive care. So I think that that's really encouraging. So when I talk about collaboration, it's really everybody. It's the individuals living with the illness. It's the family members as much as we can engage them, and sometimes they're struggling themselves. So it's not that easy to do that. It's you know, peers, and in a lot of different places where we can do this. We can do this in school-based health centers. We have very good data now about reaching kids in schools early on and providing them care. We can do this in primary care clinics. And I think that some of us have been on this journey for, you know, 10 years in this state, and we've been talking about this for some time, and now it's not 10 years ago. Now we actually have a lot of good examples of stuff that really works. And so I'm going to say just a few things about that. The first one is what we just heard from our colleagues in Clark County. So I'm super excited about what you guys were saying. Somebody had to jump in. You jumped in. You know, it's not all perfect, but you're doing a lot of good, and it's really exciting. And I think you need to share that story as much as you possibly can with as many people as will listen to you. A couple of concrete examples. We now know that if you place in a smart way a behavioral health professional into a busy primary care clinic who can work alongside a primary care provider and sort of get to things early. You have a person in the office who's got a crisis, and if you can provide a really focused, brief behavioral intervention to that person right there when they come in, you know, you're catching things upstream. You might be preventing that ER visit, that hospitalization, and you're doing it in a place where you're not carrying all the stigma that comes with mental illness. There are some real upsides. Some people are more complex than that, so we work with a lot of primary care clinics that say, that's great, but it takes more than 3 or 4 or 5 visits with a good behavioral health professional. I have a person who's living with post-traumatic stress disorder. That's not going to go away unless you're Dr. Phil on TV. That's not going to go away with 2 or 3 or 4 nice touches with a good behavioral health person. That's going to require an ongoing commitment. That's a chronic illness. This needs to be treated exactly the same way we need to treat your diabetes. We need to treat your you know, other chronic conditions, and that's when the collaborative care model can be really helpful, where you have a care coordinator, a primary care provider, and a mental health professional working together with a registry that makes sure that people don't fall through the cracks. You said several times people don't follow up. This is exactly true. We don't follow up. So we have to have you in a database where we know we started something for this person. They're not coming in. We need to go out and find them because we're not done yet. You know, and then there are cases that are even more complex than that, and that's when we have to be smart and find a good, smart way to refer to our colleagues in our community mental health centers. And when the patient is there, we have to not forget that they also have asthma and diabetes and other things. And I think the stuff that you guys have done at Kitsap, which is to say we got to put medical services here because the patients just won't go. And we now all know, and I feel ashamed, I'm a physician, and the patients we take care of in psychiatry die 20 years earlier than your age and gender matched control. And they're not dying from suicides for the most part. They're dying from strokes in their late 40s and early 50s. They're dying from undiagnosed cancers. This is stuff that's easy, you know, for a good primary care doctor. So I think that's, but we all have now examples of doing this and the fact that it can work. So how do we know what to do now. How do we go there? Just 4 thoughts I have I'd like to share. The first one is we got to keep talking about this. It takes a lot of building trust and comfort for people to come out of their silos and to say, I could share with another provider. I could, you know, even share some of my money with someone else. You know, a lot of us aren't comfortable. You know, we're all in our silos. You know, when we get scared, we draw up our walls. make a stronger argument. We argue a little louder for why we need to keep doing what we're doing. And I think that it takes a lot of trust. And I think some of you have started this, it sounds like, in Clark County to start, trusting each other, working with each other. And so far, what I'm hearing is nothing terrible has happened yet. I think we got to keep saying that to people. It's very important. The second thing is, money. Money is a huge problem. I think Peter said this, integrating the money isn't going to be the only answer, but it's incredibly important because if everybody gets paid a different way, we're never going to get to clinical integration. So a couple of really promising things. Keeping my fingers crossed for the waiver. We now have, CMS has just announced that they will have payment codes, CPT payment codes for collaborative care, where I, as a psychiatric consultant, can provide consultation to a primary care clinic that doesn't have to involve a face-to-face sit-down with a patient. I can just talk to another doctor and say, here are some things you could do. That's a very, very smart way of stretching a limited resource like me. So we're going to have payment codes for that kind of work in 2017. Telepsychiatry can make some of us quite portable. It's not a panacea, but it's a tool that makes it possible for a mental health provider. And most of the counties in the state of Washington don't have a single psychiatrist or psychologist. So some of us can be going to places 5, 6, 8 hours away and do pretty effective health care if we use telehealth in a smart way. Training is huge. None of us have learned how to do this kind of fully integrated work. Our PCPs don't know how to do it. We don't know how to do it. We're going to have to invest in some training. If we want to have really good integrated collaborative work happening in our clinical settings, we're going to have to train people how to do it. And for some of us, it means we're going to have to retrain how to do it. If we're going to have to learn, and we all need to learn, how do we work well with a peer counselor? I didn't learn that. I don't think anybody learned that. We're going to actually have to sit down and learn it. And that kind of training, there's a knowledge part that's easy. And then there's the skill part. You got to practice it until you really get good at it. And then finally, practice change is just so hard. If this stuff was easy, we'd all been doing it a long time ago. There's an enormous amount of potential if we go there. And I think we just all need to continue to commit to working at it, running down the barriers. And so the best thing I heard today is the story from Clark County. I know you've got problems, and you probably didn't talk about all of them. But the fact that it's possible and no one's died yet is something you got to keep saying. So thank you.
Great. Well, Ergen was totally appropriate, leading right into practice transformation. We started out the morning hearing from a consumer, which I think was really powerful, on how difficult it is to navigate a system, on how providers get frustrated, patients or consumers get frustrated, fall through cracks. As we go through this effort, and as we've listened to folks in Southwest Washington, there are many changes that need to take place. There are clinical practice changes that need to take place. There are administrative changes that need to take place in systems to make this work. And if we're truly going to serve consumers in the best way, there's this community clinical linkage part that connects the healthcare delivery system with housing and with public health and other human services. So in the SIM grant and in Healthier Washington, we have a commitment to help providers and systems with this practice transformation. Providers are wanting to do right to the whole person. They need the systems that can support them to do this. And we've mentioned before the quadruple aim. How do we help also provider satisfaction and providers to be successful in this kind of transition? That's what the Practice Transformation Support Hub is all about. And in your packets, and I believe it's on the left side, at least it was in mine at the very end of the left side, the back, is a handout on the Practice Transformation Support Hub. And I have done even better than have a slide or to do my own stuff. I'm like bringing Mary Beth Brown, our new practice transformation coordinator, up so that you can meet her, and she's going to quickly run with you, through with you, the handout that you've got in your packet there. So Mary Beth from the Department of Health, welcome, and off to you.
Thank you, John. Morning, everyone. So if you take a look at the graphic, I can run quickly through where we are with the hub. I know there were a lot of listening sessions and a lot of you were involved, and there have been a lot of conversations over the last year about where the hub needed to go. So we are at a state where we have an apparently successful bidder, and it's Qualis Health, and Dr. Peggy Evans is here today. And we're very close to she's over here, and we're very close to finalizing the statement of work and having that submitted to CMMI. So our hope is to have the hub on the ground in September. So just very quickly, if you look at your graphic, there are 3 contracts that make up the Practice Transformation Support Hub. 2 of them are with Qualis Health as the apparently successful bidder, one for the connector network, the other for the practice coaching facilitation contract. And then we have a 3rd contract for the web-based resource portal, which is with the University of Washington. So the way we're hoping that this works is that we'll have a presence in each of the RSAs, and we're using RSAs rather than ACHs because one of the focus points is behavioral health integration with the hub. So we'll have a presence in each of the RSAs, and the connector will work at the systems level, understanding the community clinical linkages that are there, the peer supports, the opportunities to bring inside the clinical walls for the providers to access in service of their patients. So the connector will be kind of surveying the landscape, knowing what the resources are, and providing that technical assistance and the referrals to those kinds of supports and services, and hoping to stimulate uptake of those things, and also identifying gaps where the community might need some things added. The practice coaches will be out there enrolling practices who are interested in intensive coaching services, and the goals would be to support behavioral health integration. We'll be working with the AIMS Center as one of our partners. We're fortunate in that way. Also, value-based payment will be one of the aims, as well as strengthening these community clinical linkages. And then as resources become available and they're curated at the University of Washington, they'll be posted on this resource portal. We know that providers and clinics are overwhelmed sometimes with information and knowing what is of the most value, and we're hoping to make this provider-centric, easier for you to use, understand the current environment. Qualis is really good at digging deep into whatever is most current and translating it for the people that they're on the phone with so that they can understand how whatever's happening with macro or whatever it might be will impact them, and they can make good decisions for their own practices. So that's where we're headed, and we hope that the hub becomes provider-centric, supports the practices where they are, and that we can help the other components of Healthier Washington integrate out there where it makes a difference for the providers and the patients. Thank you.
All right, so that pretty much gives you an overview of both the clinical integration, an overview of the state where we're at. Actually, some exceptional work being done. Jürgen has been on the forefront of integration for, we won't go into how many years that is, but just for a good long time. And the advances that we're making now are really coming in through. It literally, we're being brought into the forefront, which is about time. So with that, now I get to turn this over to my colleague, Teresita, and we're going to move on to clinical linkages. Okay, Teresita, and thank you, gentlemen.
So John and Jürgen, you were spared questions from the audience, and I would encourage the audience later on to, you even brought Mary Beth up just to get out of that. So let's bring up Ellie and Graydon up here. So definitely, you know, we really have heard a lot of very important things this morning. I want to underscore the bi-directional piece. I have no survey to present you from the community health center side, but I can assure you that community health centers are very definitely engaged and involved in doing this. And we do have community health centers that are fully integrated already. Yakima Valley Farm Workers Community Health Center is here. I know that the Columbia Valley Community Health Center in Wenatchee is also an RSN. So, but we are all over the place in terms of the spectrum. But I do want to recognize that one of the more important partners of International Community Health Services is ACRS, because they do they are a BHO, but also they provide a full range of services that address social determinants of health. So in talking about what we do in our community health centers, I have a couple of examples that I just want to quickly share. So homelessness has already been cited as a big issue. One of our clinics, around our community health center, we have close to 3,000 patients who are homeless, 2/3 of whom are in one of our clinics. That's Holly Park in the south end of Seattle. Most of them are youth. But when the county does its one-night count, they're not part of that count because they're not sleeping under bridges. They're not, somewhere out on the streets. They are basically living from one friend's house to another on floors, on couches. So they need a full array of services aside from what we're able to provide them. They need food. They need to have access to education, and that education is frequently interrupted because they don't have stable housing. They're unable to go to school on a regular basis. They need jobs. They're outside of their families. How are they going to survive? And so what I want to do is when Peter presented his pyramid earlier on, when he has said integrated care coordination at the top, then integrated care delivery, I can't read my own writing, so you might have to help me, Peter. Integration of medical and behavioral health systems. I think that we need to add a foundational layer at the bottom, which talks about the community services, the community linkages, something that we used to call, and I say used to call, safety net system, because that system was shredded during the recession and has not been successfully built up. But as we take a look at this, so yes, we can figure out how do we pay for the integrated care that those of us who provide physical and behavioral health, but what about all the community partners that we have that contribute to making sure that health happens? And I especially think about the partners that we have who come from emergent communities, who are the best in terms of the ability to provide the support because they know their community. So as an example, the Bhutanese community is still relatively new. Not a lot of people who have risen up yet who have gotten the kind of Western education that we require to get the certifications that we require for them to be able to serve in our settings, right? But they are the best people to be able to help and understand support because they're trusted. So that's part of the kind of thinking we have to have. And the infrastructure that we need to think about is not just the HIPAA protected infrastructure or the IT infrastructure, but what about from the perspective of people like Kay? Are we going to subject them to continuous intakes? Every single stop that we make, they have to make. And how do they get from service to service to service without being dropped along the way? We've got that one rock star in this room, who's Kay, who was able to survive that, and then be able to kind of turn around and contribute her experience and her skills and knowledge to help others. So that's part of the community linkages that we need to think about. So with that, I do want to introduce formally Graydon Andrus, who's the Director of Clinical Services for Downtown Emergency Service Center, which is here in Seattle, and Elia Moore, who's the Executive Director of Olympic Community Health.
I'll go next. Thank you. Thank you for having me here. I want to start by saying I used to say, coming to these big kind of group meetings, state of reform, HCA meetings, that if I had a penny for every time somebody said, oh, the accountable communities of health would do that, I would have more money than our entire ACH budget. I think the pendulum has swung the other way today, and I'm somewhat oddly happy to hear that we haven't heard, ACHs will do that in every breath. But I do want to, I think I'm asked today to talk about the role of accountable communities of health and whole person care. And before I start, I'll start with two kind of frames that I just wanted to mention. And the first is that, and I should say that what I'm about to share with you today has been through several sieves. It's been through all of the ACHs that have had a chance to review and provide input into these points, as well as members of my own accountable community of health, for which Joe Rozak is a board member. So first I would start by saying local knowledge about needs is critical to make wise resource allocation decisions. And there's a strong desire amongst the ACHs for local autonomy to make sure that the money is going to match and align with local priorities. The second thing I'll say is really just a language issue. We speak, I think, interchangeably about integration and whole person care. And for the purposes of what I'm about to talk through, integration, when I say integration, I'm really talking about purchasing, integration of purchasing. Whole person care is really how the ACHs talk about integration on the delivery side of care. And I say whole person care with a grain of salt because it's really most person care. And I think Joe mentioned it earlier and somebody else, it doesn't include oral health. But for the spirit of positive psychology, we'll call it whole person care. So first I'm going to start with the Olympic community of health. What value can the ACH bring, specifically the OCH? And it really boils down to 3 points. Number one is creating a functional and safe forum for exploring issues and developing actionable strategies. And I'll go into some specifics in a bit. 2 is technical assistance, and 3 is advocacy. So additionally, I should say that the Olympic community of health is very fortunate in that we are home to 7 sovereign tribal nations. These are people who have integrated care already for many years. There are no silos. They have been taking care of their people, education, transportation, behavioral health, dental, primary care, the whole array. They have figured out how to integrate social determinants of health into the equation. And we are very fortunate in the OCH to have 7 sovereign nations that we could learn from. Second, I think it's important to underscore the relationship that Joe mentioned earlier between primary care, specifically FQHCs, community mental health clinics, and rural hospitals. The OCH is very fortunate to have the CEOs, the decision makers of each of these sectors on our board. And as you can see, when you get the right people in the room together, really great things happen, as has happened in Kitsap County through Peninsula Community Health Services, Kitsap Mental Health, and the hospital. So I think I should mention the BHO and the Olympic community of health. The BHOs are young, 4 months in. There are a few observations that I was asked to share here today. The first is, and I think Bunk said it earlier when he talked about the administrative side of contracting with the BHOs being a pretty substantial administrative burden. And when you have chemical dependency providers who are new to this, who are already under extreme pressure, this can drive people out of the workforce and drive them out of the market. And this is the opposite that we want to happen. And so the question that I was asked to pose is, how do we protect, expand, and integrate the current chemical dependency capacity we have in our community in light of these changes? The second is that the BHOs, previously the RSNs, have been building trust. We talk a lot about trust at our ACH tables. They've been building trust for the last 15 years in the community. And how do we preserve this foundation of trust in light of the changes that are happening? And I'm now going to transition to kind of the broader ACH. Where do ACHs fit in clinical community linkages? And these are shared by my other ACH colleagues. Many of them are in the room, and so if there are questions, I will kind of punt them so it's not just me talking. So first, it should come as no surprise that the ACHs all agree that whole person care is necessary. It's a necessary step in the transition to the triple aim, and it absolutely must happen. Furthermore, for most, if not all of the ACHs, it is an identified regional health priority for which we will be targeting through our regional health improvement plans. The same, of course, goes for the Olympic community of health. So how? Like, let's get concrete. How can the ACHs play a role? And share this role with other state agencies. I think we heard from the Practice Transformation Hub, the Washington Health Alliance is in the room, WSHA, WSMA, the Healthcare Authority. All of these are meant to be in the spirit of collaboration. First, advocacy, advocating for what's needed at the local level. Next, convening key partners to come up with a local plan forward. Advising on the fully integrated contracts that are coming out of the MCOs. Acting as a regional data hub, tracking progress towards whole person care benchmarks in collaboration with AIM, the Analytic Interoperability and Measurement Team. The ACHs can provide a venue through which providers can collaborate on specific tactics towards whole person care. And of course, all this is in collaboration. And I have a couple of examples of key tactics that were identified by my colleagues. Identifying a shared resource, such as the 24/7 nurse line, health information exchange, or referrals to MCOs who have telephonic care management. Behavioral health workforce planning, convening and coordination of implementing a regional telepsych initiative, sharing specialized personnel, especially in our rural ACHs, such as community health workers, child psychiatrists, housing specialists, designing and putting in place agreements between chemical dependency providers and primary care providers so they could have treatment plans for their shared clients, individuals, Joe. A regional learning lab on whole person care. What is the role of the ACH in working with the Practice Transformation Hub to convene the right people to have these conversations about shared best practices, barriers, workforce development, etc. Also, the ACHs are one of the primary vehicles for the Medicaid waiver, and if whole person care is a waiver project, then the ACHs would be able to track progress towards benchmarks on whole person care, determining the ongoing viability of these new activities beyond the waiver window. And I'll end with what I call gutting the house. So I've done a lot of work on my house, and I've gutted it. And in that, you get to do a lot of things a lot differently, right? You really could, when you gut the house, you could really get in there and do things. So the ACHs have a lot on their plate. They have a lot of strategies that align with their regional health assessments. So when we're talking about whole person care, when we're going into provider practices and we're training them on integration, we're training them on referrals, we're training them on data tracking, why not also talk about addressing adverse childhood events? Why not talk about housing? Why not talk about changing opioid prescription behavior? And why not really discuss the clinical community linkages as hardwired referrals to home visiting programs, early childhood development programs, maternal support programs, senior assistance programs, and other care coordination programs. And finally, we have to start talking about integrating oral health into the primary care setting. And I'll end with this. All of this, it sounds great. I see a lot of heads nodding and smiles, but it takes money. It takes technical skills and experience on the part of the ACHs, and it has to be paid for. And so ACHs cut across all the pillars of Healthier Washington. We cut across the Practice Transformation Hub, behavioral health integration, whole person care, analytics, interoperability, and measurement. And we're asked to support all these things, but we need the resources to be able to do that.
Thank you, Elia. I will note that for community health centers, medical and oral health integration was one of the first challenges that we had to address. But the comments here really is appropriate in terms of right now oral health is not part of managed care. So.
Thanks. I'll play the rock star game. I would be an electronic musician. Partly because the only musical instrument I ever learned was a harmonica, and that was so long ago. I could do a couple of Dylan pieces if you like. But an electronic musician gets to pull in every instrument they want, when they want, and splice it all together. So that's what I want to be. Almost everything I've wanted to say today has been said in one way or the other, but I'll say it slightly differently, I suppose, and with more focus on what I think of as a higher need, high priority population that requires much more specialized interventions and solutions. And I was glad to hear comments about we don't just have a way of doing this, we have to have different ways of doing this. So we need to be more specialized. And the population or the lens that I am looking through here is many years of working with long-term homeless, otherwise known as chronically homeless individuals, adults, with very complex array of mental health, substance use, medical, and just very serious social determinants and resulting health disparities that are just very blatant. I don't need to make the speech about housing because Australia has made that. We're just nowhere without that. So I know that systems don't have that much money to just build all the housing we need, but everybody needs to keep saying that and keep believing that and know that it's a wise investment in the long run, because we will achieve so much more if we can get people stabilized in a place that they feel reasonably safe and can begin to take care of some of their own needs before we start overlaying various services. We at DESC have sort of been more like a MASH unit, I think, in terms of how we've tried to link together, various services to make sure that we were beginning to address the range of needs, because we do try to look at them as a whole person. Dentistry is out there a ways for us, but some advances are occurring. And I would say that the critical linkages we've attempted to make first, and now we're moving on though, but first has been making much tighter linkage between behavioral health and substance use treatment. We made efforts to make formal linkages to primary care the old-fashioned way by forging relationships with healthcare providers that knew our population and cared about it. So Harborview Hospital was the obvious for us. We had a clinic just 2 blocks away, but most of our clients were not accessing that health care for a variety of reasons. They tried a few things that were interesting, like opening up hours to make them more flexible. You didn't have to show up exactly at a certain time. That became somewhat difficult for them from a financial perspective, because they needed to be banging it out and getting that reimbursement, because it was never quite enough to pay for their services anyway. But we work with that, and there's just an awful lot of effort that is hand walking and repeated hand walking to appointments, through the appointment, so they don't blow out in frustration or misunderstanding something that is going on due to untreated schizophrenia and all of the confusion that they may be experiencing at that time. So it's very intensive work, and there's no shortcuts to this, but I think the linkages can be made in a variety of ways, and the more traditional ways are obviously more of this hand walking, but I think more formal agreements and ways of delivering the primary care more flexibly need to be established within the health centers. We much prefer to be looking at the co-location model, of course, because so many of the people we're working with won't go there. They're not going to just show up on time or to these various providers that may or may not be close. You're talking about people that have been on the streets for many years in many cases, not used to seeking care, may not really care about it. They just have little hope. They're thoroughly alienated, and their mental illness has been untreated largely for many years. Substance use has been layering on top of that. They have other priorities, on the day. So hand walking, and what does that mean? Well, that means you must have a certain amount of outreach and engagement effort to locate and continuously engage individuals that are not coming to you or going to any provider, and they are out there. So there's always been a shortage of this kind of service, and I would like to sort of help put that particular effort in a new context. We have managed to expand healthcare to so many people with the Affordable Care Act, and we do some of that by way of accommodations to people. We have various kinds of accommodations. So if a person is in a wheelchair and you have a DSHS office or a clinic, you're required to have a way for that wheelchair to get in your center. That is a legal required accommodation. The same could be said of a person who is out there, disorganized, severely mentally ill, disengaged. The only way they are going to access healthcare is through an assertive outreach effort. So that is an incredibly important, I think, concept that the system has not grabbed onto yet. They have benefits they're entitled to, and yet they're not really able or allowed to access them. So we have to build the accommodation and maintain the accommodation. It doesn't happen fast. It takes a constant effort to make sure this connection is made, and then further the connection to primary care and dentistry and, let alone housing. But that is how we've achieved moving people more quickly into housing, and that is how we've achieved moving people more quickly towards primary care. But we can only do it with so many, because the funding for this kind of effort is not driven by Medicaid. And so you're just picking up the scraps from wherever you can. State mental health system reduces their funding to BHOs. BHOs, cry poor because they are, and so they fund less of this kind of work. So this is a very specialized need that's out there to make sure these linkages are happening. And these are the people that are being talked about all day long. These are the very high needs, high expense population that will one day cost one hell of a lot of money when they get so sick that they land in the ICU and they don't leave there until they die. And that's often the story. And these are some of the folks that I have known personally and hear about now that I'm not a direct service provider. Either that or they're frequently ending up at the emergency department because their illness is so unmanaged and they become expensive in a different way. And I don't like to talk about money as the driver for why we should be delivering this kind of care, making these linkages happen. But I know that money matters, and good for the state to take on some of this permanent supported housing benefit in Medicaid through the 1115 waiver, although it's a pretty small pot. I think it's a good start, and it'll help play out the concept. But in the meantime, we have got to find ways to fund these other efforts that Medicaid just does not step up and pay for due to various service code requirements, lots and lots of effort that simply is not billable, therefore does not count. And that is all happening in the background. Nobody knows how much service is going on in an effort to find, engage, and provide meaningful support for people who are not engaging in traditional care. So these linkages are incredibly important and incredibly time-consuming. And front end, yeah, they're expensive, but we'll see it on the back end, as will the individuals. They will live longer and they will live better lives. I think I've made my main points, but I would like to stop though and talk about a little bit about, as we move forward and try to create much more integrated services, many of the folks that are served by a community mental health provider, I think that becomes their health home. This is where they know to go. This is where they trust people. This is where they know individuals. They have more continuous contact with mental health case managers and substance use providers. So if that's the health home, this now becomes a major other effort for each of those service providers to integrate. We used to talk about the three-legged stool, case managers. Just stay focused on making sure they're getting their mental health needs met, making sure they're getting housed, making sure they're getting some sort of income and resource so that they can live life. The fourth leg obviously was primary care, but we were not really zeroing in on that as hard as we should have, and now we are. That fourth leg is going to take a lot of time. So, caseloads can't stay what they are and continue to expect that deeper work to occur with people that have continuous and high need. So we've got to look at payment levels for behavioral health providers and help them reduce caseloads so they can thoroughly integrate primary care into their work, because I think for many people it is the health home. And just as housing is health care, just start to think about these things a little differently. Years ago, several people were talking about housing as health care, and David Wertheimer was one of them, sort of throwing this idea out there. Well, wouldn't it be dandy if a doctor could prescribe housing? Talk about taking a big step forward in a person's whole health and their immediate safety and ability to take care of some of their needs. This is the reality. So until then, we'll patch it together as people are homeless and living in shelters, and that's what we're doing right now. We have managed to work with several partners to bring primary care into our shelter soon, which is a huge step. We've not been able to do that forever because of money. We have a co-located primary care site in one of our mental health offices, our behavioral health offices. And we're also working with Neighbor Care, and they're going to be bringing some primary care into our largest permanent supportive housing building. And these are all huge achievements, because these are the sites where the lowest number of people are accessing primary care. So it'll be interesting to see what we're able to achieve. I don't think it's going deep enough, but I think it's a good start, and maybe we can figure out a way to just more routinely co-locate primary care in these key sites. I don't think every housing program needs co-located primary care, but there are clearly some who do.
So thank you so much, all of you, for your participation today. Do you have anybody have any burning questions? Yes, David. Well, we will get you out of here on time. Go ahead.
So this is not specifically a question for this panel. It's really about the whole conversation we've had this morning, but it does relate to where Graydon just went. And first, I want to thank the Physical and Behavioral Health Accelerator Committee for a really fascinating set of presentations this morning. Just great conversation. And as someone who's kind of on the periphery of this conversation in many ways, I guess I have a fear which is rooted in the Jerry Maguire question, you know, the show me the money question. And that fear is that as we drill down into the realities of the 1115 waiver and of healthcare reform and how it's playing out in Washington State, that we're going to be pushed more and more and more in the direction of the immediate short-term savings that the primary care system can realize. And we're going to lose sight of the vision that started with Kay's presentation right at the top of our meeting today, which was so valuable, about the social determinants of health that are a longer-term play and a deeper set of investments that will yield results that may be harder to measure in the short term in terms of immediate savings. And how are we as a state going to balance the pressures that we're feeling from the feds about the immediate short-term savings that we have to demonstrate we can make in order to get a waiver, in order to do whatever we're doing, and the reality of the vision that we've articulated here of a truly integrated, holistic system that meets the needs of our most vulnerable citizens.
So I'm wondering if we can't take that question, because it is the key question of this morning that I'm imagining that everyone has kind of tumbled to, which is there's short-term and long-term, there are different populations that need different things, and we're on this road, but how do we actually not only have that question be at the forefront of our minds, but how do we also figure out how to take the dollars that we have now, how do we look for new investments, and put it all together so that we can create that vision of, not the reality, I guess I would say, of, you know, I'm, you know me, 5 years from now it's probably more like 10, but that we can actually see a huge change in the overall way that we do this. I think, so let's keep that question, and I'm going to tie it back in just a minute to another thought, David, so make sure I do that. Yeah, Winfried and then Nancy.
Thank you. Could I suggest that we also then integrate the question of accountable communities of health into this conversation?
Yes.
Because I think that's exactly where the connection
That's right.
is.
Yeah.
You know, the idea of shared savings and how do we get these systems to begin to talk to each other. That's one of the key roles, in my opinion, of accountable communities
Yes.
of health.
Okay, thank you. Nancy.
So this is a question just to understand the problem a little deeper. So Graydon, how many folks do you serve a year, and what percentage of those folks have you seen for more than 1 year? Or just trying to get an idea of numbers and how long you're following them.
My mind is not so sharp as to pull those numbers right out of my head. But on a given year, DESC does a lot of different things. We see over 8,000 people, either in our shelters or permanent supportive housing, because we have like 1,300 units of permanent supportive housing, mental health programs of different types, crisis services. So it's kind of hard to pull out. I'm not sure what subset you're talking about, but you know, our whole goal in every program is to stay connected with people, whatever the service is. So it does suppress some of our numbers, and that makes it hard sometimes to argue with funders because they don't see as fast a movement as they expect. But we're so by design zeroing in on the population that has fallen literally until they're on the street, that those outcomes take longer. So I'm not quite sure how to answer your question accurately.
So, but if I could tie that also into this final piece, the data and the information that you're asking, Nancy, I think is really important that we, again, we're talking a lot today about the most of seriously mentally ill, physically ill folks that need the most robust, reliable set of services, one-on-one, hand-holding, hand-walking, I love that term, all the way up to making sure the most sophisticated clinical care and those community supports are there. So I think it's a really important question that we, as we put this picture together, need to add those numbers in so we can kind of, as we go forward, see what's actually moving forward. So a couple things. Thank you. Oh, Teresita wanted to say one more thing.
But I also want to say that, you know, the reason why we talk bidirectional all the time between primary care and mental health care is there are a lot of people who need the services, but not as intensively. And so we don't want them to get to that point where it's so intensively. And maybe they are much more appropriate, and they probably are much more appropriate in the primary care setting with shorter types of interventions. And then there's the middle part where, you know, how do we really much more effectively manage them so those who are at risk of becoming more serious don't get more serious, and those who are really very serious have the chance, to, like Kay, to really get better and be the valuable person that that person is. So, you know, so while right now a lot of the emphasis is the high cost, high intensity, high risk to produce these savings, we always need to keep in mind that, you know, this has to be about the system of care.
Absolutely, that's the most articulate closing comment for this, which is we've got to be able to understand, and this is also about just thinking, this isn't just for our Medicaid population, which is maybe a third of the state, but you know, if we start to do this within that population, it's going to, by nature, transform our systems for everyone else as well, because you know, the delivery systems and the providers and our community supports really need to be able to take care of the whole population. But I'd like to thank you guys and then end with a couple things. Thank you very much. Preston has an announcement for the good of the order.
Sure. Just want to put in a plug for the second annual Edge of Amazing Summit, which is September 9th up at the Tulalip Resort, and it's being co-sponsored by Healthier Washington, the Snohomish County Health Leadership Coalition, and the Providence Institute for Healthier Communities. The theme this year is Connecting Neighborhood to Nation, and we have several national speakers coming in. So we have Assistant Secretary of Health, Karen DeSalvo, and Patrick O'Carroll, who's coming through as the Assistant Surgeon General, and they've been traveling around the country looking at kind of best practices of what's happening in community engagement. We'll be sharing that and showing some of the unique highlights in Snohomish County. Fania Davis, who is the Executive Director for Restorative Justice for the Oakland Youth down in Oakland, California, will be speaking. Very timely topic there. And then Dr. Richard Jackson, who is a professor out of UCLA, and in terms of building healthier communities. There's 15 breakout sessions, so lots to see and do both at a national level as well as local level. So please put that on your calendars. Thank you.
And just Laura, checking with you, has that invite or hold the date gone out to everyone in here for calendaring? The notice, okay, so the notice went out for you guys in here, so you've got it in an electronic format as well. So that sounds like a fantastic day. The other thing, which is why I'm trying to tie David's and Winfried's and Nancy's comments and the other ones from today into something bigger or different, is on October 24th, and first I'll say that our next meeting date is the 21st. We're going to cancel that and hopefully people can come to this instead. This is the idea that we've been batting around and several of you have suggested, along with others, not only here but from other parts of this country, to have a kind of a symposium to tackle those bigger picture questions that were raised today, that when you see the system being in the room, what happens when you do that, and to really kind of go deep into several different areas in terms of what we have learned, what are those early system warnings that we're seeing in the early signs of what we can do, learn from others, hopefully get a couple of national provocative speakers in here, but have it be a real kind of, you know, humble, appreciative inquiry, what's working, what isn't, what can we continue to do, because we are starting to turn the systems here, and so we want to have a time to step back and do that and really take a bigger brain look at the questions such as ones David, Winfried, Nancy, Hugh, others in this room were all making comments on today. So save that date as well. I think we're going to send that as an invite out, Laura, correct? And if you have any thoughts for that, I know we're out of time right now. We'll probably be engaging in some emails or questions about how we might want to do that. We really would appreciate all of you being active participants and leaders in that symposium that's going to be coming up on October 24th. So with that, I'm not sure we have any other things. The Ambassador Toolkit updates are in your folders. Any other thoughts or for the good of the order? I would, yeah, Hugh. The time frame for the waiver. Well, okay. Okay, there's two things. There's two things on that. Nathan's always, I have actually had the opportunity to work at CMS for a little bit. And when they say any day now, that often will translate into kind of any several weeks now. So we've been waiting, as you all know, for several months. We're hopeful that by the end of this month or the very beginning of September, we'll have a hopefully positive response to that. But I think it's getting close for everyone. I think we've worked through pretty much all of the questions and issues that we've had. Just so you know, some pretty tremendous leadership here in this state. We've had some of our elected officials, national congressional members helping with that as well. So we'll have I don't know what we'll call it when we get it out, Nathan, but we'll send out an announcement, and hopefully in the next 4 to 6 weeks we'll have some positive news. That's right. Yes, exactly. And that's when you can say, well, how is that long-term services and supports fitting in, and how's the housing piece fitting in, and really begin to understand this at a more, at an even bigger level in terms of where we want to invest and where we want to move. So, any other questions? Okay, stay tuned, and we'll see you all either on the 9th and or on the 24th. Thanks very much.